Yes, we are live now.
Good afternoon, doctors, and thank you very much for joining today's webinar. I welcome all the esteemed guest speakers, dignitaries, and participants on behalf of Shield Healthcare. I would like to introduce Dr. Kavita Ma to invite all the guest speakers and for the lighting ceremony. So, ma'am is Professor and Head Department of Obs and Gynecology, CMC Ludhiana, President Ludhiana Menopause Society, and editorial board member, national and international journals. So I'm privileged to introduce ma'am, and ma'am, over to you. Thank you very much.
So much for introduction, and I welcome all for today's event. This is a webinar which is covering a very important topic on hypertensive disorders of pregnancy. And this event is being hosted by AMOGS and with the Punjab Societies, Ludhiana, Nabha, Firozpur, and Jalandhar Societies. And it's a real privilege to have Dr. Narendra Malhotra as a chief guest, and Dr. Parag Binewale and Dr. Iqbal Singh Ahuja as the guests of honor. And I must thank Dr. Sneha. She has been the driving force for today's event, and she has helped me throughout of the planning and execution of this event. And as we go on to the lectures and the panel discussions, so we will be introducing the faculties which have joined today. And I welcome all the delegates also for today's event. Thank you so much, everybody, for joining. So can I introduce Dr. Sneha, ma'am, formally? Can I have a
We go ahead with the lamp lighting first, and then we start.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
So Dr. Sneha ma'am is well known, but as a formality, I'm reading out her CV. She's the International MS Signature Award for her phenomenal leadership, not only in 2020, but she still continues and have been doing this for many, many years in Foxy. She has won many awards, and she has been recognized for her community service at the national level also. And she has 30 years of experience in OB-GYN and has delivered so many talks, orations, has many, many publications.
Thank you, Dr. Kavita. Thank you. That introduction should suffice. A very good evening to respected Dr. Narendra Malhotra, sir, chief guest for today's program, my mentor and guide in particular, Dr. Iqbal Singh Ahuja, whom I've met a number of times virtually though, but at Ludhiana CMC in person, dear friend Dr. Parag Binewale, who is the vice chair of ICU, guest of honor for today's program, respected Dr. Rajendra Singh Pardesi, who is the president amongst, and Madam Sujata Darvi, the secretary, immediate past president Dr. Nandita Palshetkar, Dr. Kiran as the incoming or president-elect of amongst, all the office bearers. I also welcome Dr. Lakshmi Shikhande, Dr. Ashok Kumar, the team ICUG, and presidents and secretaries of Ludhiana, Jalandhar, Firozpur, and Nabha societies. My dear friend, Dr. Vidya Thobi, the state president of Karnataka, Kasuga, all the esteemed faculties and delegates for today's program, a very warm welcome to all of you. At the outset, I would like to express my gratitude towards all of you for accepting my invitation and gracing the program. Dr. Gitanjali Kaur, who is the president of Ludhiana, Dr. Gini Gupta, the secretary, Dr. Kavita Bhatti, who is the convener for this program, Dr. Surjit Kaur, president of Jalandhar, Dr. Sukriti Sharma, the secretary, Dr. Dinesh Pathak, president of Firozpur, and I have witnessed your warm hospitality as I have visited your place in person as well. So friends, thank you so much for joining this program. And as all of you know, hypertension, hemorrhage and sex factors, the maternal characteristics, HTP gestational score, the various biophysical and biochemical markers, the incidence of mortality and morbidity which is associated with hypertension disorders has still not reduced. Maybe in fact it is rising to some extent. So friends, it is indeed there is a need for making awareness amongst obsgynae friends, using these predictive measures, and of course utilizing the whatever modalities are those calcium, vitamin D and magnesium, of course early diagnosis, prompt treatment, so as to minimize the complications associated with, and of course the mortality which is related to this. So with this intention, we have planned out this program, and we have wonderful faculty. So once again, I welcome all of you here, and with this, I take all the guests of honors as well. So I welcome respected Dr. Narendra Malhotra, who I have already said he's a mentor and guide to me in person. Sir is the past president of FOXIC, ISPAT, and so many other organizations. The CV is so long. So I just say that he is a very good human being, very humble in spite of reaching to such an height. So I personally invite you, sir, for this program, and we are eager to listen to your precious words and have your blessings. Over to you, sir, Narendra Malhotra.
A very good evening to all of you. It's indeed a pleasure and so nice to see that AMOG's Society from Maharashtra is organizing webinars and seminars for North India. That is what exactly integration of our country means, that we need to integrate our country, and wherever the experts are, they should be addressing and interacting with everyone all over India, even to the villages. Of course, this new normal of conferences not being there or being there and the webinars continuing at this scale is a great boon to medical education. And I welcome and my dear friend Dr. Iqbal Ahuja, who I know him since very maybe since childhood, since just after MD. We've been known each other when we were doing IVF in Ludhiana and Jalandhar. And Parag Binawala, of course, is very close friend of ours. Thank you, Dr. Pardesi and Dr. Dalvi, for organizing this for Nabha, Ludhiana, Jalandhar, and Firozpur. And I'm sure that we are all going to benefit with PIH. PIH, let me tell you, is 15%. And as Sneha mentioned, the mortality is reduced only marginally. So maybe we're not diagnosing it properly. Maybe we're not treating it properly. Maybe something is wrong in our understanding because of being very busy. So we do screening tests in pregnancy. So it is very important now to add PIH screening to our genetic screening. The genetic problems arise 1 in 800. PIH arises 15 in 100. So PIH screening has to be added in the first trimester in the markers. So instead of double marker, we're going to do a penta marker in the first trimester. And what I would urge is all of you to get proper blood pressure measurement. You know, blood pressure measurement is usually done in busy clinics, lying down wherever with whoever. It should be done in sitting position, both arms on the table, BP instrument on the table at the level of the heart, and then measured. And then we should be calculating the mean arterial pressure, MAP, which is again a scrolling and a rollover test, which you can do clinically in your clinic when the patient is lying down. And of course, then order the biochemical markers, which are available to us now. Like now, SFLIT is also going to be available very soon. But the faulty placentation gives you faulty markers, PIGF and PAP. And these markers, the MOs, if you're not within the range, will predict PIH. Why it is necessary to predict PIH before 16 weeks? Because we can start a very, very simple intervention of aspirin. Aspirin has to be started before 16 weeks. After 16 weeks, the trials have shown it does not work for prevention of late PIH. But if you start at right time, that is the time for starting of it. So congratulations, Sneha Huyar. All the best to you for your forthcoming Foxy election also. We are definitely going to be your full-fledged open supporters in this election. And all the best to all of you. Happy learning with PIH. Thank you very much for inviting me here to this webinar.
Thank you so much. Thank you, sir, for that wonderful insight into the subject. And very, very well, you have taken us to the basics of the subject. So thank you for all your blessings and thanks personally from my side. Prachi, can we have Dr. Iqbal Singh Ahuja, CV? So, sir, I know him since last few years and met him virtually a lot of times. I just said, sir is such a senior and illustrious person, still very humble and very inclusive. Sir has a very senior obstetrician from Ludhiana, and he was the first, I would say a pioneer in the test tube baby center at his own Iqbal nursing home. He is felicited with numerous awards, right, from state president and IMA award, and also the by the deputy district governor. He was felicited with the Lions International award as well. So many awards and accolades, but we are just waiting for your precious words, sir, and we hand over the mic to you for your blessings.
It's nice to be a part of this webinar. It makes me young. And first, I thank you, Dr. Sneha. It's always a pleasure to meet you, and it's very pleasant. You give pleasant vibes. So very nice to see you. And then I talk to Dr. Malhotra. They say Agra is famous for Taj Mahal, but I always say Agra is famous for Dr. Malhotra. Because he worked so much in IVF and for obstetrics and gynae and made famous. My aunts are here, Dr. Kavita and Dr. Gitanjali, who keep me busy in Ludhiana Obstetrics Society. Dr. Paral, I met last time. Very nice to see you. Dr. Chima, she's based in Jalandhar. Very nice. I think it's a galaxy of doctors. Karnataka, I forgot the name, but it's nice to see you. Hypertension, I was just reading it. Picture is always changing. Gynae has changed so much. When we were students, it was all mechanical, practical work. Now it is a machine work. You got ultrasound, you got everything. The procedure which we did earlier become obsolete, version and whatnot, destructive operations. But we have seen, I think, you can't imagine even the new generation. And it's good. Hypertension is always hyper. That is, this makes hyper to doctor, hyper to patients. Everybody is hyper, and suddenly it comes sometimes. And you are blamed because you didn't check earlier. Although you might have checked there, it can visit you suddenly. It's like an uninvited guest. And it creates complications for you if you don't have anything at home to give to the guest. When guests come, same thing with the hypertension. I won't take much time, but I thank you from my heart. I feel young when I see young girls, and thank you. And I also learn. It's still learning phase for me, even after so many years. Thank you, Dr. Malhotra, for giving me nice words. And Taj Mahal, and you are known for Agra. So thank you very much. Thank you.
Thank you so much, sir, for your blessings and very nice words. And now I invite our dear friend, Dr. Parag Biniwale, who is the Vice Chairperson of ICUG and, of course, the past President of Pune Obs Gynae Society. I think, Prachi, you can stop sharing. We will straightway have
think Sneha has lost.
Sneha has lost connection.
Doesn't
I
matter.
think Dr. Parag, welcome.
Thank you, Sneha, for the invitation. President AMOGS, Dr. Rajendra Singh Pardesi, Secretary General, Dr. Sujata Dalvi, Chief Guest of today's program, and dear friend, Dr. Narendra Malhotra. Pleasure to see Dr. Iqbal Singh Ahuja after a very, very long time, and all the friends in Jalandhar, Ludhiana societies which I have visited, and Firozpur and Nabha societies which I have not visited. So good evening from the beautiful city of Pune. It's a pleasure to be sitting here with you all. Sneha, I must compliment you for choosing a very important topic, that is hypertensive disorders in pregnancy, because though we know a lot, there are still a lot of things which we don't know. And then when the patient comes in and poses a challenge, we are really in a soup and we really struggle to manage her. I must compliment Dr. Rajendra Singh Pardesi, who has taken AMOGS beyond the boundaries of Maharashtra and reached out to other parts of countries for exchange of knowledge. Hats off to you, because reaching out now has become easy when we start virtually, and it's a good gesture to interact with colleagues all across the country. So once again, Sneha, thank you for having me here, at my best wishes for your forthcoming elections.
Thank you, Parag. Thank you so much for your best wishes, and of course, the wonderful words about the program and the societies as well. So actually, Dr. Pardesi sir has not joined initially to change the sequence, and definitely I welcome Dr. Rajendra Singh Pardesi, who is the AMOGS president, past chairperson of the Food and Drug Committee of FOXI, and a wonderful human being, and of course my mentor in person. I request you, sir, to have your few words of wisdom.
Good afternoon, everybody. Respected Chief Guest, Dr. Narendra Malhotra sir, Dr. Parag Binewale, and Dr. Iqbal Singh Ahuja, Dr. Sujata Dalvi, Dr. Vidya Thubi, President of Kasoga, and friends. See, I'm very happy to join this program, as Dr. Sneha has now bridging the bridge between Punjab and AMOGS, and she has joined Punjab and AMOGS, as Dr. Malhotra told, for this divine webinar on SDP, as SDP has been still a cause of maternal mortality, and 10 to 15% cause of maternal mortality, and we have to curb it. And she has taken really a nice initiative, and I wish every success to Dr. Sneha Bhuya for her future endeavor in FOXI as Vice President. I again congratulate all the societies, Ludhiana, Jalandhar, Nabha, and Firozpur, for taking this initiative of hypertensive disease in pregnancy and to curb it. I again congratulate, and I wish every success to this webinar. I wish every success to Dr. Sneha Bhuya. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you for your wonderful words. It's always a guiding force behind us, Sadar, I would say. A very good evening, Madam Sujata Dalvi, who is the AMOGS secretary and a wonderful human being, who is so very helpful, always guiding to me. Yes, and Madam, I'm very eager to listen to you. Over to you, Madam.
Thank you. Thank you, Dr. Sneha. It's my proud privilege to be addressing all of you all as an secretary of AMOGS. I would like to express my gratitude to Dr. Rajendra Singh Pardesi, President AMOGS, for always encouraging the scientific sessions. I would also like to express my gratitude to AMOGS Medical Disorder Committee, Dr. Sneha Bhuya, who's always there in forefront so far as the scientific commitment is concerned. And today she has managed to have this webinar along with Ludhiana, Jalandhar, Nabha, and Firozpur OBGYN Society. I would like to acknowledge the words of wisdom given by our chief guest, Dr. Narendra Malhotra, and also a guest of honor, Dr. Parag Binewale and Dr. Iqbal Singh Ahuja. Would like to express the support given by SCOG office bearers, Dr. Lakshmi Srikhande and Dr. Ashok Kumar, and of course, Kasoga President, Dr. Vidya Thobi. Yes, and today's webinar is on HDP, which is very important topic. And I'm sure those who have logged in will learn a lot, and they'll be able to practice whatever they've learned in their clinical practice, which will be for the betterment of the patient. And I would like to wish Dr. Sneha for her future endeavor in FOXI and also for today's webinar. Thank you so much.
Thank you so much, madam. Thank you for your blessings. And with this, I declare that the program is inaugurated, and I thank all the dignitaries, respected Dr. Narendra Malhotra sir, Dr. Iqbal Singh Ahuja, Dr. Parag Biniwale, Dr. Rajendra Singh Pardesi, and Madam Sujata Dalvi, all the presidents and secretaries of all the 4 societies which I have already talked about, Ludhiana, the Firozpur, of course, Jalandhar and Nabha societies, and all the faculties, Dr. Parni, Dr. Professor Chima, and Dr. Vidya and myself, we are going to moderate the panel, very interesting panel. So I thank all of you. And with this, I hand over the mic to Dr. Kavita for the academic session. Thank you so much once again.
Thank you, ma'am. And I think we have to move on to the academic session. So for the first session, that is the first lecture, which is on prediction and prevention of hypertensive disorder of pregnancy. We have Dr. Surjit Kaur as the chairperson. She's a gynecologist obstetrician practicing at Jalandhar, laparoscopic and hysteroscopic surgeon, colposcopist, as well as an IVF specialist. She's the president of Jalandhar Obs and Gynae Society and the vice president of Islam Punjab chapter. She's also the past chapter secretary of Jalandhar Menopause Society. So we welcome Dr. Surjit Kaur as the first chairperson, and Dr. Gitanjali Kaur. She's the president of Ludhiana Obs and Gynae Society. She's the director and senior consultant at PAL Hospital, Ludhiana, with 24 years of clinical experience. She has been the organizing secretary, North Zone Yuva Foxy 2022, and is also the secretary of Society of Fetal Medicine in Ludhiana. She has chaired and given lectures at various national and state level conferences, and has special interest in high-risk obstetrics, ultrasound, laparoscopic surgery, and infertility. So we welcome Dr. Gitanjali Kaur as the chairperson for the first lecture on prediction and prevention of hypertensive disorders. I will request the chairpersons to please introduce the speaker, Dr. Parneet Kaur.
Dear friends, all the viewers on this virtual platform, Chief guest Dr. Narendra Malhotra, Dr. Iqbal Singh Ahuja, Dr. Parag Biniwale, Dr. Sujata, Dr. Rajendra Prasad, and all the faculty members, good evening to all of you. First of all, I thank AMOX for inviting me and providing this platform. Today, we are going to discuss about the hypertensive disorders, prevention and prediction. As we all know, hypertensive disorders are the leading cause for morbidity and mortality among the mothers and the neonates, and requiring the resources for the hospitalization and intensive care. So prevention is when we diagnose in the prenatal period about the hypertensive disorders, then it is easy to manage. And once there is no antenatal care and they come neglected in the late stages, there are the clonic seizures, patient goes in the eclampsia, and unnecessary complications and mortality and morbidity are associated with it. So now we are going to listen from Dr. Parneet Kaur. She is a professor and head of the Department of OB-GYN, GMC Patiala. She has a teaching experience of 21 years. She is examiner for undergraduates and postgraduates for last 13 years. She has 56 publications in various national and international journals. She has contributed 3 chapters in books. Reviewer of 2 reputed specialty journals. President of NAVA Obstetric and Gynecological Society. Her special interests are high-risk pregnancy, emergency obstetrics, contraception. She is a master trainer for PPI UCD. She is a member of FOXY, ICOG, IMS, IAG, PCO Society, NARCHI, SFM, SCLSI, and IMA. Now, the platform is yours, madam. You can start. I invite Dr. Puneet for the deliberation.
Thank you, Dr. Sujit, for that introduction. And my thanks to MOGs, Dr. Sneha, and of course, Dr. Kavita for inviting me for this very important webinar. So I will be talking on screening for prediction and prevention of preeclampsia. I am unable to move my slides.
Just click on the slide, double, and then you will be able to move it.
Double click.
Yeah, yes.
Thank you. Thank you, Dr. Sneha. So it is first trimester screening for prediction and prevention of preeclampsia. So I will be talking about where the need for prediction and what are the methods for prediction of preeclampsia and what the guidelines say, and finally the FICO recommendations and what do we do for prevention of preeclampsia. So preeclampsia is a major cause of maternal and perinatal morbidity and mortality, and is thought to be predominantly as a consequence of impaired placentation. Women in low-resource countries are at a higher risk of developing preeclampsia compared with those in high-resource countries. The hypertensive disorders contribute to 18% of maternal deaths. Also, hypertensive disorders of pregnancy are accountable for 1/3 of preterm deliveries and related perinatal deaths. Preeclampsia can be divided into early onset preeclampsia when the delivery is required before 34 weeks of gestation, and late onset preeclampsia when the delivery is required at equal to or more than 34 weeks. The classification is not mutually exclusive, as early onset preeclampsia is associated with a higher incidence of adverse outcome both for the mother and the fetus. A major challenge in modern obstetrics is early identification of pregnancies at high risk of preeclampsia, so that necessary measures can be initiated early enough to improve placentation and thus prevent or at least reduce the frequency of its occurrence. Extensive research in the last 20 years, mainly as consequence of the shift in screening for aneuploidies from the second to the first trimester of pregnancy, has identified a series of early biophysical and biochemical markers of impaired placentation. Now, for prediction of preeclampsia, we will learn the predictors in three parts: the maternal risk factors, the biophysical markers, and the biochemical markers. In the maternal risk factors associated with preeclampsia, it has been demonstrated that maternal demographic characteristics, including medical and obstetrical history, are potentially useful in screening for preeclampsia. Now, these are maternal age. Advanced maternal age equal to more than 35 years is associated with 1.2 to 3-fold increased risk of developing preeclampsia. However, maternal age is not associated with increased risk of early onset preeclampsia. Parity: there is an increased risk of developing preeclampsia in nulliparous women. Parous women without history of preeclampsia have reduced risk of preeclampsia. However, this protective effect is lost when the conception partner is different. Previous history of preeclampsia: the incidence of preeclampsia increases with subsequent pregnancy if there is history of preeclampsia in prior pregnancy. And the studies show that this risk is 14.7% in the second pregnancy for women with a history of preeclampsia in their first pregnancy. And it rises to 31.9% for women who had preeclampsia in previous 2 pregnancies. Interval in between pregnancies: both short and long interpregnancy intervals are associated with an increased risk of preeclampsia. A study reported that interpregnancy intervals of less than 12 months or greater than 72 months are associated with higher risk of preeclampsia development compared with interpregnancy intervals of 12 to 23 months. ART pregnancies: it has been reported in many studies that the use of ART technologies doubles the risk of preeclampsia. Family history: daughters or sisters of women with preeclampsia are 3 to 4 times more likely to develop the condition than women without a family history. The mode of inheritance seems to be complex. Genome-wide associated studies of preeclampsia affected families have demonstrated significant linkage to certain chromosomes. Obesity remains a very high risk for preeclampsia, and evidence shows that BMI of 30 or more than or equal to 30 confers 2 to 4-fold higher risk of preeclampsia. Race and ethnicity, the risk of preeclampsia is also higher in women of South Asian origin than in those of non-Hispanic white women. Certain medical conditions that predispose women to developing preeclampsia are hyperglycemia in pregnancy, type 1 or type 2 diabetes mellitus, gestational diabetes, especially if requiring insulin, pre-existing chronic hypertension, or autoimmune diseases such as SLE and antiphospholipid syndrome. Now we come to the biophysical markers. The two biophysical markers are most important are MAP, which is mean arterial pressure, and uterine artery pulsatility index.
मोटी को ना faculty link बोल के बोलना तेरे laptop से खोल दे.
Mean arterial pressure. Mean arterial pressure. Am I audible?
Yes, yes. Dr. Parneet, you're audible, but I think we have to mute.
Mute others, yeah.
No, it's something from my side, ma'am.
No worries.
No.
So shall I continue?
Yes, please.
So mean arterial pressure is an important sign as it is an early indication of disease. Accurate monitoring of BP during antenatal care is very important. The rate of cuff deflation, the use of correct size cuff, the interarm difference in blood pressure, and the arm position and posture are recognized to have significant effects on blood pressure determination. The introduction of automated blood pressure monitoring allows simple, standardized method, and also repeated measurements can be taken. We will learn more about this in the next part of lecture. Then comes the uterine artery pulsatility index. The most promising screening test for preeclampsia is uterine artery Doppler velocimeter. The spiral arteries undergo series of morphological changes during normal pregnancy. The vessels are firstly invaded by trophoblasts, which then becomes incorporated into the vessel wall and replaces the endothelium and muscular layer. This results in the conversion of the small spiral arteries into vessels of greater diameter with low resistance and high compliance. The underlying mechanism for the development of preeclampsia is thought to be impaired trophoblastic invasion of the maternal spiral arteries and their conversion from narrow muscular vessels to wide non-muscular channels. Doppler ultrasound provides a non-invasive method for the assessment of the uteroplacental circulation. The finding of impaired placental perfusion is reflected by increased uterine artery pulsatility index. Next are the various biochemical markers. Now they say more than 100 biochemical markers have been studied for the prediction of preeclampsia, which includes fetal DNA, hematocrit, vitamin D, ILGF, PLGF, PAPA, and soluble FMS like tyrosine kinase. But the two most studied are PAPA and PLGF, which have been investigated extensively. Now, PAPA, which is pregnancy-associated plasma protein A, is a sensitive trophoblast-derived metalloproteinase, which enhances the mitogenic function of the insulin-like growth factors by cleaving the complex formed between such growth factors and their binding proteins. The insulin-like growth factor system is believed to play an important role in placental growth and development. Thus, low serum PAPA is associated with a higher incidence of preeclampsia. Then the PLGF. PLGF, a glycosylated dimeric glycoprotein, and is synthesized in villus and extravillus cytotrophoblast. It's a member of the vascular endothelial growth factor subfamily. It binds to vascular endothelial growth factor receptor 1, which has been shown to rise in pregnancy. Preeclampsia is associated with reduced placental production of PLGF. Screening by biochemical markers, the first trimester maternal serum concentration of PAPA and PLGF have been shown to be affected by gestational age at screening, maternal weight, racial origin, cigarette smoking, conception by IVF, nulliparity, and pre-existing diabetes mellitus. Thus, the measured concentration of PAPA and PLGF must be adjusted for these variables before comparing results with pathological pregnancies. The mom values of PAPA and PLGF are significantly reduced at 11 to 13 weeks gestation in women who subsequently develop preeclampsia. Now, what the guidelines say. Analogous to the effective first trimester combined screening for aneuploidies, effective screening for preeclampsia can also be achieved by a combination of maternal factors and biochemical and biophysical markers. Now, according to the Foxy ICOG, they have given us a gestosis score, where each risk factor has been given a score. It may be 1. We have already studied the risk factors. It may be 2 score or it may be 3 score. So this score involves all the existing and emerging risk factors in the pregnant women. Score 1, 2, 3 is allotted to each clinical risk factor as per its severity and in development of preeclampsia. With careful history and assessment of women, a total score is obtained from time to time because it's a dynamic score. It may change over the course of pregnancy. When total score is equal to or more than 3, a pregnant woman should be marked at risk for preeclampsia. Now, according to the NICE in the UK, women should be considered to be high risk of developing preeclampsia if they have any one high risk factor as enumerated, which are hypertensive disease in previous pregnancy, chronic hypertension, renal disease or diabetes, or any 2 moderate risk factors like nulliparity, age, BMI and family history. Similarly, ACOG says that they may be labeled if they have 1 high risk factor, again same chronic hypertension, type 1 or 2 diabetes or renal disease, or 2 or more than 2 moderate risk factors like nulliparity, obesity, family history, etc. Now, the approach recommended by NICE and ACOG essentially treat each risk factor as a separate screening test with additive detection rate and screen positive rate. In screening with use of NICE guidelines, the detection rate is 39% for preterm preeclampsia and 34% for term preeclampsia at 10.3 false positive rate. The respective detection rate in screening with the use of US Preventive Services Task Force recommendation were 90% for preterm preeclampsia, 89% for term preeclampsia, but with a very high false positive rate of 64.3%. An alternative is to combine the maternal characteristics and previous history into an algorithm derived by multivariate analysis to estimate individual patient-specific risk for preeclampsia. So now comes the FIGO recommendations. Bias-based method combines prior information from maternal characteristics and medical history, UTPI, mean arterial pressure, maternal serum associated plasma protein and placental growth factor at 11 to 13 weeks gestation, and can identify a high proportion of pregnancies at high risk for early onset preeclampsia. So FIGO has come up with guidelines for screening for preeclampsia in first trimester and endorses the multivariate model of Fetal Medicine Foundation. So FIGO supports the use of risk-based screening using biomarkers for the first trimester prediction of preeclampsia over screening method that use maternal demographic characteristics and medical history only. So FIGO again identifies the maternal risk factors, which we have already studied all of them, like maternal age, weight, height, ethnicity, family history, smoking habits, chronic hypertension, and other systemic diseases. So here we can see in this diagram that as we move to the left, the risk for preeclampsia increases, and as we move to the right, the risk is less. See, if the height is more, the risk will be less. Again, if there is Paris women without history of preeclampsia, the risk will be less. So then there are certain recommendations for measurement of blood pressure, MAP. MAP should be measured as part of risk assessment for preeclampsia, and it should be measured by validated, automated and semi-automated devices. Women should be in sitting position with their arms well supported at the level of their heart, and appropriate sized adult cuff should be used, depending on the mid-arm circumference. After rest for 5 minutes, blood pressure is measured in both arms simultaneously, and 2 sets of recordings are made at 1 minute interval. So ideally 4 sets of recordings should be there, but then 2 sets are acceptable because these are more practical. And finally, final MAP measurement will be used for the calculation of patient-specific risk. So here, as Dr. Malhotra was also saying, BP is very important. The legs should be uncrossed. Either the position of the chair should be adjustable or the position of the table should be adjustable so that the arms are at the level of heart and BP app lies on the table. So MAP is calculated from systolic and diastolic reading. The measured systolic and diastolic blood pressure will be automatically converted to MAP by the risk calculator. But this is how basically we calculate the MAP. Then regarding the uterine artery pulsatility index, the measurement of UTPI must be carried out by sonographers who have received the appropriate certificate of competence from Fetal Medicine Foundation. This is endorsed by FIGO. Using transabdominal ultrasonography, a sagittal section of the uterus should be obtained and the cervical canal and internal cervical os are identified. Subsequently, the transducer is gently tilted from side to side and color flow mapping is used to identify each uterine artery along the side of the cervix and uterus at the level of internal os. When three similar consecutive waveforms are obtained, the PI is measured and the mean PI of the left and right uterine arteries is calculated. It is important to ensure that the peak systolic velocity is greater than 60 centimeters per second to ensure that the arcuate artery is not being sampled instead of the uterine artery. A transabdominal ultrasound scan should be done at 11 to 13 weeks, 6 days period of gestation with a crown rump length of 40 to 84 mm. Gestational age must be determined from the measurement of the fetal CRL. Persistent high impedance to flow in the uterine arteries is evidence of poor placentation that manifests itself in the form of abnormal uteroplacental flow velocity waveforms. FIGO acknowledges and endorses the guidance from ISUOG and with regard to UTPI measured methodology. The first trimester abnormal UTPI is defined as greater than 90th percentile, but this is about average of 1.66 at 13 weeks of gestation. Then regarding the placental growth factor, several studies have shown that women who subsequently develop preeclampsia have significantly lower maternal PLGF concentration in the first trimester than those with normal pregnancy. Similarly, PAPA is a well-established biochemical marker in the screening of trisomies 21, 18, and 30. As a single marker, it is not an accurate predictor test for preeclampsia, but if it is available for aneuploidy screening, then it should definitely be incorporated while calculating the risk. So combined risk assessment means published algorithms should be used for converting the measured values of MAP, PLGF, and UTPI with or without PAPA into MOMs as detailed above. Patient-specific risk for preterm preeclampsia is calculated using the bias-based method. The risk calculator is available free of charge on the webpage fetalmedicine.org and on the Fetal Medicine Foundation mobile app as well. It is also available on medical records software. So this is what they try to say, that if we combine MAP, UTPI and PLGF, then the detection rate of preterm preeclampsia is about 74.8%. But for term preeclampsia, it never goes beyond 40 to 45%. So the detection rate is more for preterm preeclampsia, and of course this is more harmful for the mother as well as the baby. But if we combine PAPA along with, the detection rate hardly improves. It almost remains the same, 74.8%. That is why they say the most important are maternal risk factors, MAP, UTPI and PLGF. But of course, if PAPA is available, it should be incorporating while doing risk assessment. So FIGO adopts and supports a Fetal Medicine Foundation provision that all pregnant women should be screened for preterm preeclampsia by the first trimester combined test with maternal risk factors, MAP, UTPI and PLGF as a one-step procedure. The best combined test is one that includes maternal risk factors, measurements of mean arterial pressure, serum placental growth factor and uterine artery pulsatility index. If PAPA is measured for routine first trimester screening for fetal aneuploidies, the result can be included for preeclampsia risk assessment. A woman is considered high risk when the risk is greater than or equal to 1 in 100 based on the first trimester combined test with maternal risk factors, MAP, PLGF and UTPI. Then comes the contingent screening. So they say that in low resource countries, the biochemical and markers may not be available. So where resources are limited, routine screening for preterm preeclampsia by maternal factors and MAP should be done in all pregnancies. and the measurements of PLGF and UTPI are reserved for a subgroup of population selected on the basis of risk derived from screening by maternal factors, and MAP can be considered. So this is what they say in contingent screening, that total population should be screened. So in a way, universal screening. So first stage screening by maternal risk factors and MAP. If it is negative, then the patient is screened negative. If it is positive, then we go for second stage screening, which consists of UTPI and PLGF. And if they come out to be positive, the patient is labeled as screen positive. So regarding multiple pregnancies, the same first trimester combined test for preeclampsia and singleton pregnancies can be adapted for screening in twin pregnancies. It leads to the detection of nearly all affected cases of preeclampsia, but at a high screen positive rate. So regarding the prevention of preeclampsia, there are 2 recommendations for prevention of preeclampsia, which are acceptable by all the guidelines. So all at-risk women should be started with aspirin 75 to 150 milligram. So optimal dose of aspirin is unclear because studies are saying 60, 75, 100 and 150. ACOG recommends 81 milligram per day. Foxy ICOG says 75 milligram per day. And FIGO recommends that all high risk should receive aspirin prophylaxis commencing at 11 to 14 weeks, 6 days of pregnancy at a dose of 150 milligram per day to be taken every night until 36 weeks of gestation when delivery occurs or when preeclampsia is diagnosed. And optimally, aspirin should be started before 16 weeks to have maximum benefit. The second recommendation is regarding calcium supplementation. So FIGO recommends 1.5 to 2 gram of elemental calcium supplementation. It may reduce the burden of both early and late onset preeclampsia. There are other interventions which are mentioned regarding, it may be vitamin D, vitamin C, vitamin E, sildenafil, but because they are not still in the proven efficacy for prediction of preeclampsia, so I have not included that in very much detail. So this is a pathway for screening as told by FIGO. So maternal characteristics, medical and obstetrical history, measurement of MAP, measurement of PLGF, a biochemical marker, and measurement of UTPI, a biophysical marker. Combined risk assessment with maternal risk factors, MAP, PLGF, and UTPI should be done at 11 to 13 weeks, 6 days of period of gestation. If the screen is low risk, if the screen population is low risk, that means less than 1 in 100, routine prenatal care should be given. But if they are high risk, equal to more than 1 in 100, then we should start with aspirin 150 milligram at night from 11 to 14 weeks, 6 day period of gestation, and continue till 36 weeks of pregnancy. So in conclusion, early estimation of patient-specific risk for pregnancy complications would improve pregnancy outcome by shifting prenatal care from a series of routine visits to a more individualized patient and disease-specific approach, both in terms of schedule and content of such visits. In the case of preeclampsia, effective early identification of the high-risk group could potentially improve the outcome by directing such patients to tertiary care centers and specialist clinics for close surveillance. Thank you so much for patient hearing.
I will request the chairpersons to please give their comments and expert opinion.
So, thank you, Dr. Pandit, for such an excellent presentation. So, incidence of preeclampsia, we have to first find out the cases where there is a high-risk pregnancy, especially ART, obesity, family history, and racial history. And if there are high-risk cases, then they should be properly followed. First, we can do the biophysical markers, mean arterial blood pressure, uterine artery Doppler, PI, and biochemical markers, PEPA and PGLF, they can be tested. If PEPA is less than 0.4, it is a high-risk case for the preeclampsia. Then surrounding the FIGO, uterine artery PI, MAP, PEPA, A and PGLFF, they are very important. And proper blood pressure checking in a proper sitting position of the patient and keeping the blood pressure instrument in front on the table. That's also very important to take the blood pressure in a proper position. So high risk cases, they should all be investigated at between 11 to 13 weeks between the CRL 42 to 84 millimeters. And the high PI is in the uterine arteries is a indication for start the aspirin in proper doses at proper time. That is going to be more helpful. If it is start between 11 to 13 weeks, that will keep the many complications, can prevent the many complications. So conclusion is that MAP, TLGF, UTPI, and PEPA, A biochemical markers, they are very important to test. And prevention is better than the problem of the pre-eclampsia. So thank you, Dr. Paneet, for such an excellent presentation.
Thank you, Dr. Sudhir. Thank you for those remarks.
So I would like to thank the chairpersons and the speaker and invite the next speaker and the chairpersons for the second lecture. So the next topic is management of hypertensive disorders of pregnancy. And for this, we have Dr. Harinder Ubroy. She's a consultant obstetrician gynecologist and infertility specialist practicing at Jalandhar. She's the IFS chapter secretary of Punjab and also has various positions in SR and IMS. And she has many credits to her. She has organized and conducted various CMEs and ART workshops as well, attended many national and international conferences. So I invite and welcome Dr. Harinder Kaur Ubroy. Our next chairperson is Dr. Sangeeta Agarwal. A warm welcome to her. She's an associate professor, Department of Obs and Gynae, Government Medical College, Patiala, straight trainer for RKSK Adolescent Health, life member of various organizations, and her special interest is in high-risk pregnancy and menopausal health. So I welcome you both, and I will request you to please formally introduce our next speaker.
Good evening to all of you. I'm Dr. Harinder Kaur Ubroy. It's my honor and great privilege to be here on this virtual platform. First of all, I thanks to Dr. Mrs. Kavita Bhatti for inviting me for this beautiful webinar. Thank you so much, madam. And I introduced Dr. Hani Chima for her deliberation. She is a great academician, ever smiling and a dynamic personality. She did MBBS, MD, Ops and Gynae, best graduate of the university. She did advanced course in medical education, fellowship in Philadelphia, USA. She did master degree in international medical education and research. She did many publications in various international journals, and she participated in many international conferences and got Best Paper Award at International Gynecological Conference at Switzerland, Zurich. It's going to be great boon for all of us. We welcome and acknowledge your presence, madam. We do get hypertensive disorder in pregnancy in our day-to-day practice. And over to Dr. Chima for her beautiful deliberation.
Very good evening to all of you. Thanks, dear Dr. Mrs. Ubroy, for very special words for me. And I thank you from the core of my heart. And I thank the organizers and especially dear Dr. Kavita Bhatti for giving me the opportunity to be here in front of you. And I thank the previous speaker as well, Dr. Parneet. She did a very wonderful job and she did great justice to her topic. And that was very great listening to you, dear ma'am, Dr. Parneet. Nice meeting you. So if you permit, so should I start my topic and should I share my screen? Dr. Kavita, ma'am, should I start?
Yes, please. We are waiting to hear.
Yeah, my topic for today is management of hypertensive disorders in pregnancy. And let me start and let you know, since all the senior professors and senior obstetricians and gynecologists of the whole India, pan-India, they are here. So everyone knows that it is the spectrum of disorders, which is ranging from already existing chronic hypertension in the index pregnancy to complex multi-system disorder like preeclampsia. And it leads to many of the complications like eclampsia, HELP syndrome, acute renal failure, pulmonary edema, stroke, and left ventricular failure. And if I go by WHO data, the recent data tells us that 19% maternal deaths are there still occurring from this. And many of the deaths, they are occurring because of preeclampsia, and 1.7% maternal mortality is there of eclampsia. If I find the challenges in the management, then due to certain myths and misconceptions in pregnancy and the low socioeconomic status of the people and lack of easy and expert antenatal care, which really requires multidisciplinary approach, and there is lack of adequate and accurate prediction methods, and definitely in the rural areas we have challenges in the transport facilities so that the patient may be shifted to the HDU unit well in time. So there remains an unmet need in the recognizing and managing the HDPs. And as far as the maternal alerts are concerned, because we have already learned a lot many good things from dear Dr. Paneet, and she has told us about everything and about the predictions and the prevention. And now I am talking about the maternal alerts. So there are following signs and symptoms, and the investigation, they want an urgent and prompt management. In cases of persistent headache, and this headache is usually frontal or occipital, or it is a new onset of headache which is unresponsive to any kind of treatment. Blurring of vision, difficulty in breathing, second trimester vomiting and epigastric pain, feeling of ill-being of patient, uncontrolled hypertension, oliguria, brisk tendon reflexes, altered sensorium, and sudden onset of massive edema. And if I go by the lab investigations which show the maternal alerts, if SpO2 is less than 95%, LDH more than 800, LDH, if it is going more than 600 units per L, that significantly tells us about the hemolysis which is going on in the body. And serum creatinine, if the values are more than 1.1 milligram per deciliter, or it becomes double than the previous finding, then it also causes alert for the doctor about the patient. And if the AST and ALT ratio is 2 times the normal ratio, and out of these two, AST is the one which starts growing faster first, and these values, they are inversely proportional to the count of the platelets. If the platelet count is decreasing, then the AST and the ALT, they will be on the increasing side. And this shows periportal necrosis if the AST and ALT, they are increased. And serum uric acid, if it's more than 8 milligram per deciliter, raises an alarm. So amply told by dear Dr. Paneet about the measurement of the blood pressure, because it should be at the level of the heart. Mercury manometer should be used. After 20 weeks of gestation, the lady should either be in the sitting position or she should be in the left lateral position. Here I want to add on one thing. If the machine with which we are measuring the blood pressure is automated one, it needs to be validated, because nowadays many machines are there in the market which show very low finding of the blood pressure. So validated automatic machines can be used, or otherwise calibrated equipment should be used, and minimum 2 readings, as ma'am has told us that in doing MAP, there should be 4 readings 1 minute apart, but many of the FICOG or ACOG guidelines tell us earlier, if the patient is on the domiciliary treatment 4 hours apart, earlier they were saying, but nowadays they say that it is, if you get 2 readings within 15 minutes, this shows that the problem is there. And they have added that in the ideal conditions, the patient should not have taken 30 minutes before the recording of BP any caffeine or tobacco. But in our settings, when the patient is coming up in emergency, unbooked case, naturally we do not expect this ideal atmosphere there. So we need to take care. If we within 5 minutes we are getting high blood pressure readings, then we must immediately start taking the action. And in maternal alerts, apart from the symptoms, if we have a proteinuria, and the significant proteinuria is urinary excretion of more than 300 milligrams of protein in 24 hours. But however, if this proteinuria is absent also and the patient is presenting with hypertension, you need not worry or think that proteinuria is not there. Now she is not a case of preeclampsia. Nowadays, various studies they have told us, including our FOGSI and ICOG justosis guidelines, they tell us that if proteinuria is not there and BP is high, this is a atypical variant of preeclampsia, which has of late been diagnosed. And if we want to diagnose, proteinuria in the urine, then immediately we have to do urinary dipstick method, which is an automated device, or else if it is not there, then spot urine protein creatinine ratio can also be done. And they have set a value that if it is coming more than 2+, that is a very significant, we take it as. Why do not we take more than one as significant? Because 77% of the cases they become false positive, and if we take 3+, then 7% of the cases they become false negative. So they have chosen a in-between variety, that if it is more than 2+, we should consider that it is a significant proteinuria. And the results of spot protein creatinine also will be available within 2 to 4 hours. And it is very convenient for women at risk. And we must be doing this urinary dipstick method to note these particular things. As far as the laboratory investigations they are concerned, when the BP is more than 140/90, or she's a case of chronic hypertension and she visits to us for the first time in the antenatal clinic, then we have to find out whether she is having hypertensive disease of pregnancy, and simultaneously we have to assess the severity of the disease as well. So certain baseline investigations, which include urine albumin by dipstick method, or urine protein creatinine ratio, or CBC with a special focus on platelet count and the anemia assessment, because we must not forget that there is hemoconcentration will be there and false anemia finding, or because of hemolysis, the HB levels can be low. The liver enzymes, ALT, AST, and LDH, serum bilirubin. Serum bilirubin is the last to grow. First, AST, ALT, LDH, and platelet count will be decreased, and thereafter will be the turn of serum bilirubin to raise. Serum creatinine, as I told you earlier, more than 1.1 or double the finding of the previous one. Serum uric acid more than 8. Additional laboratory investigation, coagulation profile if the platelet count is less than 1 lakh per millimeter cube, and serum electrolytes in severe diseases. When we want to do ultrasonography, now here there are two parts: maternal ultrasonography, whole abdomen and pelvis should be done, and we have to look for the liver, to look for the subcapsular hematoma, or whether any hepatomegaly is there. We look for any renal signs of hypertension or other changes in the renal parenchyma. The presence of ascites and pleural effusion as other worsening signs of preeclampsia should be noted. Apart from doing the fetal surveillance and placental morphological, the obstetrical ultrasonography with Doppler. Here, patient is coming to us for the first time. Definitely, we are going to do fetal biometry. We are going to look for amniotic fluid volume, the uterine artery Doppler. In the earlier stages, as Dr. Pandit has told us beautifully, that the uterine artery Doppler has a value, because that is a part of the screening test. But once it is diagnosed and we are doing serial ultrasonography, then there comes the value of umbilical artery Doppler. And when the cases are confirmed, then we do serial ultrasonography for all these particular findings. And more significant is if there is a high resistance or absence or reversal of the end diastolic flow in the uterine artery with appropriate further management, and the umbilical artery should also be considered. Placental location, morphology. In HDP, there are many chances of abruptio placenta, or we have to look for the presence of sinusoids or the abnormal adherence of the placenta, and early signs of premature aging of the placenta, they are also found. Calcifications are there. Fundoscopy should also be done. It is to be done to differentiate between the chronic and the new onset of the disease, and to diagnose the papilloedema or the hemorrhages. because they are having the bad prognosis. Additional imaging 2D maternal echo is required in special situations where mother is at a higher risk of developing cardiovascular complications in case of obesity, etc. Chest X-ray with shield X-ray may be necessary in certain situations where we expect ARDS and pulmonary edema or pulmonary embolism. The patients who go into HELP syndrome, there are more, and those patients are more liable to go in for ARDS or pulmonary edema or pulmonary embolism. MRI for brain imaging may be necessary for diagnostic dilemma to consider whether the encephalopathy is because of eclampsia or venous sinus thrombosis or any CVA has occurred. So in routine, this is not recommended universally for all cases of eclampsia. If we talk of medical management, World Organization Justosis recommends systolic. Our aim should be to have blood pressure around 140/90 or just between 135 to 85. That if it is above, then that really warrants we should really start antihypertensive treatment. And the target should be that the range should be between 135 to 85 or less than 140/90. But at all costs, try to avoid hypotension. It should not occur. Let us talk about the newer drugs of late which are being used. So for mild preeclampsia, we use labetalol. The dosage is 200 to 1200 milligram per day in 2 divided dosage. It is accepted as the first line and effective treatment. And one very important thing, every patient, whosoever comes to us, we think that the first line of treatment is labetalol. But we have to check the baseline pulse. If the baseline pulse is more than 100, then it is a drug of choice. Contraindications are bradycardia, diabetes mellitus, congestive cardiac failure, and asthma. If we talk of nifedipine, the dosage is between 20 to 120 milligram per day of slow releasing preparations in 2 to 3 divided dosage. Preferred medication when the baseline pulse is less than 100. Now, always make it a point, look at the pulse more than 100, start labetalol, less than 100, start with nifedipine. Maternal adverse effects, they include tachycardia, palpitations, and facial flushings, and never administer nifedipine sublingually. Very, very important thing. Methyl dopa, earlier it was being used, nowadays very less available in the market. The dosage is 500 to 2000 milligram per day, orally in 2 or 3 divided dosage. And definitely 2 days postpartum, if you have put your patient on methyl dopa, you have to stop it to avoid the risk of having postpartum depression. And the drugs contraindicated in pregnancy, the antihypertensives, they are ACE inhibitors, ARBs, and beta blockers and diuretics. Antihypertensives in severe preeclampsia, nifedipine 10 to 30 milligrams orally, not sublingually. If BP is not controlled, we can repeat it within 30 to 45 minutes. And maximum total dose of 120 milligrams should not be exceeded. And once it is controlled, slow release preparations are to be started. And in labetalol, we can start with slow IV injections, 10 to 20 milligrams IV, then 10 to 80 milligrams every 20 to 30 minutes, maximum total dose of 300 milligrams. It should not be exceeded. Or alternatively, with the infusion pump, intravenous infusion can be started after initial loading dose, and infusion can be started at the rate of 1 to 2 milligrams per minute and is titrated until we have the desired effect. And once the patient regains consciousness, then oral tablet can be started in the dosage of starting doses 200 milligrams. And if I talk of the other drugs, we have hydralazine with us, 5 milligram IV or intramuscular, then 5 to 10 milligrams every 20 to 40 minutes. Once BP is controlled, repeat every 3 hours. For infusion, 0.5 to 10 milligram per hour. And if no success is reached with 20 milligrams IV or 30 milligram IM, consider another drug. Actually, one problem there is with hydralazine. If we have to give it, we have to preload the patient. We have to give her the fluids. And in this condition of HTP, we should avoid giving maximum fluids. I am going to talk about this particular point in the later slides. And if I count off nicardipine, the average starting dose is 1.5 milligram per hour, and it can be increased up to 6 milligram per hour for desired effect according to 0.5 microgram per kg per minute equation. And it is 100 times more water soluble than nifedipine, so it can be administered IV, making it an easily titrable IV calcium channel blocker. If the patient, we feel that pre-monitory symptoms they have started and the BP is uncontrollable, for seizure prevention, immediately we should start with the loading dose of magnesium sulfate in all cases of severe preeclampsia. Now a question arises whether we should give inpatient treatment or we should call the patient as an outpatient and we should start doing the management. Now here are the certain guidelines given by the Foxy ICOG Justosis team, that in gestational hypertension and preeclampsia without any severe features, ambulatory treatment at home with frequent maternal and fetal evaluation or combination of in-clinic or ambulatory approaches. And in fetal monitoring, you have to check for the fetal growth 3 to 4 weekly. I am talking of the mild cases here. Doppler and AFI 2 weeks, especially ACOG tells us that you must go in for Doppler ultrasonography in routine at 28 weeks, 32 and 36 weeks of gestation, and NST should be done weekly. Maternal monitoring, BP monitoring, of course, will be regularly, it will be taken care of, and weekly laboratory investigations are to be done as guided by ACOG. In severe preeclampsia, the hospitalization is very, very mandatory, and patient, if the another indication is there, if patient cannot adhere to the frequent monitoring and doesn't show compliance to the treatment, so then you have to guide the relatives and have to counsel them that hospitalization is mandatory to have better maternal and fetal effects. And the conditions which preclude expectant treatment, they are maternal conditions, are that whatever the period of gestation, if these are the conditions, we have to think for the active treatment. Uncontrolled severe range blood pressure, persistent systolic blood pressure 160 or 110, and if it is not responsive to antihypertensive medication, if headaches are there refractory to treatment, if there is epigastric pain or right upper quadrant pain unresponsive to repeated analgesics, visual disturbances, motor defects, altered sensorium, stroke, myocardial infarction, HELP syndrome, new or worsening renal dysfunction, pulmonary edema, eclampsia, suspected acute placental abruption, or vaginal bleeding in the absence of placenta previa, means it showing the signs of abruptio placenta. Now, these are the maternal conditions which immediately warn us that to stop the expectant treatment and start the active management now. And the fetal indications, if there is abnormal fetal testing, fetal death is there, fetus without expectation, for survival at the time of maternal diagnosis, if there is any lethal anomaly or extreme prematurity, less than 24 weeks, persistent reversed and diastolic flow in the umbilical artery is there, then irrespective of the gestational age, you must start the active treatment. Now, how to make a decision that the delivery should be conducted? In gestational hypertension, pregnancy can be continued under monitoring till the term. Mild preeclampsia to be delivered at 37 completed weeks. Severe preeclampsia should be delivered after the 34 completed weeks. Eclampsia should be delivered once the mother is stabilized after magnesium sulfate. Labor induction should be done with the appropriate method. It can be done safely. There is as such no indication for C-section just because of the hypertensive diseases of pregnancy. C-section is done only for obstetrical indications, and we can prefer here regional anesthesia, and which can be either the spinal anesthesia or the epidural anesthesia. Of course, one contraindication is there, epidural hematoma. The chances are there, but the chances are low, especially if the platelet count is less than 75,000. And we have to avoid preload in C-section cases, though we have to give the regional anesthesia. Earlier, people in back days used to say that the GA is preferable, but here we do not advocate the general anesthesia for these patients. Why? Because the chances of aspiration are there, the laryngotracheal tube is already inflamed, there is edema, the failed intubation, more pressure, cerebral pressure it increases so many risk factors, they increase if we start with the general anesthesia. And if the delivery decision should be carefully decided after assessing the maternal and the fetal risks. Now, what the latest guidelines tell us about the corticosteroids? They say that these are recommended in all women delivering before 34 completed weeks. And if we are going to do the elective C-section, then before 38 completed weeks. And we have got two options: intramuscular dexamethasone, 6 milligrams, 12 hourly, 4 doses, and intramuscular betamethasone, 12 milligram, 24 hours, 2 doses can be given to reduce the neonatal respiratory distress. Now, one very, very important point is that even a single dose of steroid, if it is given at least 1 hour prior to the delivery, can also reduce the neonatal respiratory distress syndrome remarkably. So in case the patient has not been given, you can give even 1 hour before the delivery. So management of eclampsia, how to do it? We all know that the principle of ABCD, they are there, and it is the teamwork and the all the people knowledgeable, they are required for effective management. And in the principles of management, we should call for help. Whosoever is present, do not feel shy. Call everyone who's there, maybe a nurse, maybe a helper. So first of all, for A, you have to take care of the airway, put the patient in lateral decubitus position, use mouth gag and neck extension, try to avoid injury to the mother, breathing, nasal oxygen and suction, use pulse oximeter, saturation should be more than 96%. In circulation, IV assess for maternal resuscitation should be immediately done. Laboratory investigations are immediately sent, and you should use crystalloids, either ringer lactate or normal saline. Very important point, not more than 80 ml per hour. This is the maintenance dose fluid which should be given so as to avoid pulmonary edema in these cases. And control of convulsions with magnesium sulfate, loading and the maintenance dose. Catheterization should immediately be done with the Foley's catheter, and control of the blood pressure with antihypertensives and corticosteroids for gestational rate should be given. And delivery should be conducted once the mother is stabilized. Now, magnesium sulfate is the safest drug recommended as a first choice pharmacotherapy for eclampsia, and Pritchard regime is the preferred regime worldwide. And now one important thing here comes, we have got 50% ampules, and these should be used preferably because it is easy to count the dosage since each ampule contains 1 grams. And it is very easy for dose calculation. And important a point, do not forget it, that magnesium sulfate has to be continued 24 hours after delivery or after the last convulsions, whichever is the last. And serum magnesium monitoring is not required in routine. So let us find out what the Pritchard regime is. Total 14 grams is given, 4 grams slow IV as 20 ml, 20% solution plus 5 grams, 50% solution deep intramuscular. Let us see how. When intravenous dose is given, 4 grams, 4 ampule of 50% magnesium sulfate plus 12 ml distilled water in 20 ml syringe, slow IV at the rate of 1 gram over 1 minute. And intramuscular 5 grams means 5 ampules of 50% magnesium sulfate plus half ml 2% xylocaine, deep intramuscular in 10 cc syringe with 20 gauge needle in each buttock. And maintenance doses with 5 grams deep intramuscular in alternative buttock 4 hourly, and intramuscular then it is to be continued in alternate buttock. Now, maintenance dose will only be given if the following parameters they are met. Respiratory rate should always be more than 16 per minute. Patellar reflexes should be present. Urine output more than 100 ml in the last 4 hours. Absence of above parameters, they denote the different approach. Then we should stop giving this. Zoo-span is another regime. Pritchard was the intramuscular regime with the loading IV dosage. Zoo-span is the intravenous regime. Here loading dose 4 grams, low IV as 20 ml solution is given. This is the intravenous is the same. Maintenance dose is 5 grams to be added in 500 ml of ringer lactate, and 100 ml per hour. That means 1 gram per hour is given, and preferably we should use the infusion pump here. Now, what happens if there is magnesium sulfate toxicity or how to manage it. We should stop further dosage of magnesium sulfate. Oxygen should be started. And if the patient is having respiratory paralysis, immediately intubation, if required, should be given. And immediately we should have, once we start magnesium sulfate in our pocket, we should be having injection calcium gluconate 10 ml, 10% is given, slow IV over 10 minutes with ECG monitoring, and injection furosemide to accelerate the excretion of the drug should be started, and immediately it gives us good results. When I was searching through the literature, I found many important points, so I wanted to highlight those. That in case the patient is having a recurrent fit, you have given the full dosage of magnesium sulfate, one starts thinking that should I start any phenobarbital, should I start with any midazolam, or should I give IV diazepam if another fit occurs and the patient has already got his treatment. Now the recommendations are that recurrent fit should be treated with a further dose of 2 grams to 4 grams IV over 5 to 15 minutes. One very, very important point I want to highlight to all gynecologists across India, that I have seen many of the, junior gynecologists using magnesium sulfate once they think that the gestational age is less, and with magnesium sulfate patient has settled down, then they again start the expectant treatment and they keep on continuing the expectant treatment till the conditions worsen. Now many of the studies, they are letting us know that if you do this, there is a great risk of skeletal adverse effects in the neonate following prolonged or repeated usage of magnesium sulfate. So maternal administration for longer than 5 to 7 days associated with skeletal adverse effects of the neonate along with hypocalcemia and hypermagnesemia is there. These are the nice guidelines and many of the studies are coming up with this. So once you have started magnesium sulfate, the mother has been stabilized, proceed with the delivery. Management after stabilization, deliver the patient after stabilization in situations like eclampsia, HELP syndrome, severe preeclampsia, chronic hypertension with superimposed preeclampsia, and if gestational age is more than or equal to 34 weeks. Vaginal delivery may be considered if attainable in reasonable amount of time. In case of preterm pregnancy, expectant management can be considered with individual assessment and antenatal steroid and antihypertensive with close supervision. When gestational age is 24 weeks, immediate delivery is a better option, and mothers with chronic hypertension can be offered expectant management under close supervision. And approach should be individualized between the gestational age of 24 to 33 weeks, as no evidence exists, because we have to take care of the mother as well as of the fetus. But mother is our of main priority, and we cannot risk mother for the sake of the fetus. So intrapartum management is preferable to conduct a delivery in a well-equipped birthing center where we have the facilities of a senior obstetrician and accessible obstetric high dependency unit is there. We have got critical care units or any ICU, blood bank facilities. We have anesthetists with us, proper neonatologist and an NICU unit, and a transfer facility is there if need be. Mode of delivery depends upon the factors: urgency to deliver, the cervical Bishop score, gestational age, severity of FGR, the Doppler study findings in the umbilical artery. Induction of labor should be offered to mothers eligible for vaginal delivery. Now, if we want to give induction, so prostaglandins, dinoprost, gel, suppositories or tablets can be used. Even misoprostol may be also used if patients removed from term. Mechanical dilatation of the cervix with Foley's balloon or vaginal hygroscopic dilators may be considered. Augmentation of labor is to be done only and only with oxytocin. Now, indications for cesarean delivery: severe fetal growth restriction, or reversal of end-diastolic flow in the umbilical artery on color Doppler, or any critical contraindication for vaginal delivery, or the patient has failure of induction of labor and it makes a cesarean delivery a preferred choice. When we talk of fluid management, inappropriate and overloading of the fluids should be avoided to avoid pulmonary edema and maternal death. Fluid restriction is advisable to reduce the risk of fluid overload in intrapartum and the postpartum period. Even with hydralazine, we have to give fluid in advance, and while giving regional anesthesia, try to avoid the preload. As I've told you earlier, no fluid expansion should be used, and the total fluid restriction it should be 80 ml per hour, the maintenance fluid, or 1 ml per kg per hour. Additional 700 ml can be used for nonsensical loss. Crystalloids like ringer lactate or normal saline, they are preferably used. Intrapartum fetal monitoring, we should have the close monitoring of the fetus with continuous or intermittent Doppler device or CTG machines. Laboratory investigations may be repeated if required. And to prevent PPH, we should be doing the active management of third stage of labor and prophylactic administration of oxytocin in case of cesarean delivery should be followed in all cases. Even in normal delivery also, we have use oxytocin. Ergometrines are avoided, and it is safe to use oxytocin 5 units bolus equally diluted over 2 to 3 minutes, or prostaglandin injections can also be given. PG can also be used as misoprostol sublingual, transrectal or transvaginal. Average blood loss of labor may not be well tolerated by these patients due to hemoconcentration and underlying endothelial dysfunction, hypertension, and the use of magnesium sulfate, because it is a smooth muscle relaxant. Basically, it makes the patient more prone to PPH. The use of fluids should be judicious. Recommendation is 80 ml per hour or 1 ml per kg per hour, as over infusion may lead to pulmonary edema in these women. Post-delivery management, we should have close vigilance for eclampsia, PPH, because postpartum eclampsia is also very common. The risk factors for pulmonary edema, cardiovascular and cerebrovascular events, thromboembolic complications are there. So continued postpartum surveillance has to be done to prevent additional morbidity. During the hospital stay, blood pressure should be closely monitored for the first 48 hours post-delivery, and postpartum use of NSAIDs should be avoided. But ACOG guidelines tell us that we can use NSAIDs. Antihypertensive therapy is recommended for persistent blood pressure of systolic more than 50 and diastolic more than 100. And they say that postpartum, you can even use enarpryl maleate, or some recommendations are there that even atenolol can also be used. And lactation is not a problem. Mother on antihypertensives can lactate the baby. Persistent BP of 160 by 110 should be treated within 1 hour, and magnesium sulfate should be considered for seizure prophylaxis. Now, when you decide the planning of the patient, then after stabilization, discharge should be considered with instructions for home surveillance and regular follow-up. And the patient should be made aware of the warning signs and the symptoms, and the importance of reporting to the hospital in case they encounter any of those symptoms. Post-discharge management includes home BP monitoring by self or visiting the health professional. It should be regularly practiced, and OPD review must be done within 3 to 5 days or earlier if any pre-monitory symptoms they exist. In the postpartum care, the patients should be closely watched for 3 months with advice regarding antihypertensive medication and regular visits. They should be guided and encouraged to use contraception for at least a period of 2 to 3 years. The preferred method will be an IUCD or barrier methods or vasectomy by the husband. But the important thing is the patient should be discouraged to use hormonal contraceptives, and they should be consulted regarding the importance of preconception counseling in the subsequent pregnancy. And this kind of patient, they really is long-term surveillance is demanded, and every mother should be advised this long-term surveillance, because we know that there is a long-term risk of chronic hypertension, IHD, cerebrovascular disease, kidney disease, diabetes mellitus, thromboembolism, hypothyroidism, and impaired memory. Now, while the certain guidelines are there, if from one center a patient is to be shifted to the tertiary center, what things should be done? When patient is shifted to a better facility, following measures should be taken. Magnesium sulfate loading dose of Pritchard regime must be given and informed to the referral center. Antihypertensives in the form of nifedipine 20 milligrams slow release or tablet labetalol 200 milligram orally, along with the regular antihypertensive hypertensive if already being taken by the patient, no sublingual nifedipine should be given. Dexamethasone 8 mg or betamethasone 12 mg injection intramuscular strat for fetal lung maturity if gestational age is less than 37 weeks, and transfer the patient with the attendant, and monitoring and written information to the receiving center should be given along with the eclampsia kit. Thank you so much for your patient hearing. Thank you so much.
Thank you so much, Dr. Chima. Very wonderful and excellent presentation. You left no corners left for this hypertensive disorder, and you have very well summarized all the maternal alerts like LDH is more, blurring of vision, pain in the epigastrium, nausea, vomiting, and the all AST, LT, if it is increased more than 2 times, then one should be very careful and do the active management of preeclampsia. You have very well summarized all the medical treatment, antihypertensive drugs, and what are the precautions. And thank you so much.
Thank you, ma'am.
Over to Dr. Sangeeta. I think she is not here. So
she's here, but I think she's muted.
So she is muted.
Yeah.
Okay.
Good evening. Yes, thank you very much, Emogs and Dr. Kavita, for making me the part of this webinar. Dr. Chima has given the practical tips of management of this hypertensive disease of pregnancy. She has given all the details right from the prediction, the unmet need of recognizing the HTP is there nowadays. And we have, there are maternal alerts. There should be proper measurement of blood pressure, which is very important, as has been stressed by both the speakers. Then there should be done ultrasonography. Whole abdomen is also important for detecting any pathology in the liver, abdomen, then in the kidneys, then in the ascitic fluid in the pelvis to see the severity of the disease. Then umbilical artery Doppler is also important for severity, for seeing the fetal growth rate retardation, for any decreased blood flow, then reversal, then absent, then reversal. Then fundoscopy. Fundoscopy should be done, then 2D echo should be done. Then regarding the management, labetalol is commonly used, then we can use nifedipine. Then for the severe cases, hospitalization is required. Then one thing we always, then they have very clearly defined when to deliver. When platelet count is less than 75, we should avoid giving spinal anesthesia. Otherwise, we are taking these cases under spinal anesthesia only, and we should not preload these cases. Then even a single dose of steroid is very good. So we must give a dose of steroid before, as soon as the patient comes. Even a single dose of steroid 1 hour before the delivery is helpful to prevent the ARDS in the neonate. Then overload, then all other magnesium sulfate should be given in the Pritchard regime. So Dr. Chima has covered the topic very beautifully. So one thing I want to clear about, if we give maximum dose of labetalol and the BP is not controlled, still the patient is eclampsia or severe preeclampsia, and BP is still 170, 110. What is the next line of drug you use? After labetalol, we have given maximum dose.
If you have given maximum dose and the BP is unresponsive,
then
can you hear me?
Yes, I can hear you.
And immediately we should start with the mag sulfate therapy.
Medself, we have started, Medself. Patient is of severe preeclampsia. Impending features are there. We have started Medself. We are
Then
giving
you can-
labetalol. So what we should prefer?
You should prefer then with the ECG monitoring and everything, you should either give hydralazine or you can give nifedipine to the patient, and by the time you try to deliver the patient, you start induction and everything. Because ultimate treatment is the BP will come lower as she delivers. Or in case not getting any kind of a effect, then immediately C-section should be taken for the benefit of the mother.
Oh. Thank you, Dr.
Yeah, I think I think she has explained it well, but we will be having the case discussions and we will take these issues ahead in the panel discussion. That she has rightly pointed out that even with maximum dose of labetalol, if she doesn't respond, that is a time where you have to add the second antihypertensives. That can be nifedipine as well. Of course, your patient has got such a severe hypertension, so you have to give prophylactic magnesium sulfate as well. Thank you so much. I think Dr. Kavita, should we go ahead with the panel discussion?
Yes, ma'am. I would like to thank both the speakers. Actually, they have done a wonderful job and taken up the vast topics of prediction and prevention as well as management. Beautifully, they have presented. I also want to thank the chairpersons because for the expert comments and accepting our invitation of joining today's webinar. Thank you so much.
Yes.
So shall we move on to the panel discussion, which is a case-based discussion on hypertensive disorder of pregnancy. And to moderate this session, we have Dr. Sneha Burrier ma'am and Dr. Vidya Tobi ma'am. So Dr. Sneha, we have already introduced and she's told me to be very short for the introductions. Ma'am is looking forward for your votes for the Vice President from the West Zone. So please remember that. And our next moderator is Dr. Vidya Tobi ma'am. She's President Kasoga 2023 to 24. And she's also professor and heading the department at Al-Amin Medical College, Vidyapur. Ma'am is also very reputed and also a great academician. I welcome Dr. Vidya Tobi.
Thank you very much. Thank you very much.
So the panelist for our panel discussion is Dr. Gini Gupta. She is my friend. She's the secretary of OBS and Gynae Society at Ludhiana, ex-PGI Chandigarh, and has special interest in safe motherhood, high-risk pregnancy, and gynecology as well. The next panelist is Dr. Dinesh Pathak. He is also the president of Firozpur OBS and Gynae Society, and the founder secretary actually from Firozpur, Punjab. Special interest in high-risk pregnancy, maternal mortality, and minimal invasive surgery. We welcome you, Dr. Dinesh. Dr. Richa Dhawan, she's a gynecologist, District Hospital, Firozpur, Punjab, and she has various positions like District Nodal Officer for Lakshay, Master Trainer for CSC, SPA, Lakshay, and PPIUCD. And she's a Vice President of Firozpur OB-GYN Society. Welcome, Dr. Richa. Dr. Deepika Garg is also the Executive Committee member of Ludhiana OBS and Gynae Society. And she's a very active member of our society, visiting consultant at IV Hospital, Khanna, and special interest in high-risk obstetrics. She's been practicing for over 16 years now.
Thank you, ma'am.
And Dr. Aarti Gupta, she is a senior consultant in OBS and Gynae, Mohan Oswal Hospital, ex-associate professor, CMC Ludhiana, has a field of interest in infertility, laparoscopy, and high-risk obstetrics. Welcome, Dr. Aarti.
Thank you, ma'am.
Thank you so much, Dr. Kavita, and I would like to welcome all our panelists. Of course, I welcome my dear friend, Dr. Vidya Tobi, who has just been introduced, the Kasoga president, and I welcome all the panelists here. Already we have taken your name, Dr. Gini Gupta, Dr. Dinesh Pathak, Dr. Richa Dhawan, Dr. Deepika Garg, and Dr. Aarti Tuli. So a very warm welcome to all of you. As we have to discuss the cases which are so very important and of practical importance and of use in day-to-day practice for the common practicing obstetrician as well. So friends, women are not dying, as we have been discussing about the maternal mortality rates and ratios. So friends, these are not only rates and ratios, these are not only numbers and figures, but these are women whom the faces we have seen in the phases of their agony, distress, and despair. And these are the ones which keep on haunting our dreams. So Professor Mohammed Patullah, who is a past president of FIGO, he said that women are dying not because of the disease we cannot treat, but because societies have yet to make their decision that their lives are worth saving. So this we have discussed during the inauguration itself, that yes, HDP should draw all of our attention, and we should be able to predict so that we can identify which are the women who are at risk. And once we identify them, we can apply certain preventive measures like low dose aspirin. We can identify by this various measure, as Dr. Narendra Malhotra also stressed on this, BP measurement, which even as a busy senior practitioner, we have to take the blood pressure personally on our own, and it has to be in the sitting position, preferably in the right upper arm, maybe both arms. And then the patient has to be mentally and physically relaxed. Her bladder should be empty. She should not have consumed any drugs, including tea, coffee, and maybe even the eye drops may not have, been added at least a few hours prior to this examination. So these are various predictive factors, and in spite of this, we're not able to predict that this lady is going to develop hypertensive disorders of pregnancy, and we are not able to recognize her, identify her during her early phase of development of hypertensive disorders, so that we can prevent the complications. So just have a look at this case, which we usually face in day-to-day practice. So we start with Dr. Ginny Gupta. Dr. Ginny, you have this 22-year-old primary gravida belonging to a low socioeconomic status, and she has no significant medical history, no family history as well. She's antenatally booked with you, and up till now, everything is fine. All of a sudden, at 32 weeks, when she comes for a routine examination, you find her blood pressure record is 140/90 millimeter of mercury. So I would ask you whether you label her as having hypertensive disorders of pregnancy, if yes, when, and whether you would like to hospitalize this woman, or whether you would like to start on her antihypertensives. Over to you, Dr. Ginny Gupta.
Thank you, ma'am. Am I audible?
Yes, yes.
Yes. This is a beautiful case, which is an everyday occurrence in India everywhere. Well, she has got a first record of 140/90. She's a primary and a low SE status. These are again high risk factors for development of severe disease also. And my ears are alert, and we are now going to put her aside and do a repeat record. And we will also try to follow the protocol of the BP, checking, where the legs should be uncrossed and the BP cuff, etc. And once it is established that this is 140/90, this patient is 32 weeks. She needs expectant management, but can we give her expectant management? That is what I need to assess, and I would like to keep her under observation for at least 48 hours to be able to investigate her and look at her in totality with respect to the general physical exam, whether there is sudden edema, any history of blurring. We go through the history all over again, whether there is epigastric hypochondrial pain, there is any CNS symptoms, any feeling of illness, or any feeling of deja vu or whatever not being there that the patient is telling. I would like to assess her in totality, and it's a kind of a triaging, whether can I do an expectant OPD, or is she having some hidden severe symptom. Her blood pressure is falling into the mild variety, but I cannot go away with that. We will have to do her CBC, her LFT, her LDH, her creatinine, and her urine dipsticks for protein. I will do everything, and if allowed, she's
just for a moment, I would like to interrupt Dr. Ginny, because you have given a very good message here. Looking at the blood pressure of 140/90, you should not either label her as having mild hypertension and let her go home. neither do her hospitalize immediately and keep her, extensive management. So the very well delivered message here is, you will go according to the alarming symptoms and signs, whether she has any, and you will investigate her whether she has any severity of these features. So according to this, you will categorize her as non-severe or severe hypertension. Previously, we used to have mild, moderate, severe, but now the concept is that you can have only severe or non-severe hypertension. And once upon a time, we used to think, Dr. Gini, that, people used to say the products of conception are the culprit. So once they are out, the patient will be relieved. But I'm sure you will also believe that we are getting cases of postpartum eclampsia and even postpartum hypertension as well. So this is not the case. And very well, you have said that this is a period where you have to take this pregnancy ahead in a conservative or expectant manner, seeing that, the mother is stable and the fetus is going well. So over to you once again.
Yes, I take this opportunity. I just want to add here, Sneha, many times the blood pressure is very deceptive, and with 140-90 millimeters of mercury also, I have seen patient throwing convulsions.
Absolutely. Absolutely. Yes, ma'am. Another thing which I wanted to add, we have established the high blood pressure. We are just categorizing her whether we can do an expectant or can we not. At that opportunity, I will give her a steroid. I will not lose this opportunity, because even if she is mild, a week later, she might get accelerated. She's primary low SE status. These are alarm bells. They get very bad. They come back with total anasarca and throw a fit in your OPD while on labetalol.
Absolutely.
So now we go with Dr. Richa now.
One last thing, ma'am.
Yes.
Low socioeconomic status. I don't want to scare them. I'm admitting you for the, you tell them we are keeping you for observation with all the inpatient records, because medical legally you have to do it. You get time to give steroid. You get time to get the reports. Sometimes in our institutes, we used to send reports and send the patient home, and they would come back convulsing with the reports not collected. So we keep her under observation, which is practically inpatient, but then they get less scared. And then it is proven whether you can send her home in 48 hours with the profile of investigations and with her BP trend, and you complete your steroid also.
And
our
urinary proteins as well. Yes.
Ma'am, I have a different viewpoint. My patient has a single recording of BP. We can't just label her as having hypertension. Maybe she's having white coat hypertension, or she's just from.
Yeah, Dr. Deepika, I think she very well talked about it, that once you have a high blood pressure, one single reading, we do not label her. You repeat it after 5 minutes immediately, and Dr. Gini has very nicely explained that you repeat the blood pressure after 4 to 6 hours, and then you label her as hypertensive. So very rightly discussed, Dr. Deepika. Now we go to Dr. Richa, and I would just ask you what all investigation you want to do for this lady to categorize her as severe or non-severe hypertension. Can you just enlist and tell me the importance of each of the investigations?
Yes, ma'am. First, to categorize for, hello, am I audible?
Yes.
Good evening, ma'am. Ma'am, first to label her as severe hypertension, as Dr. Gini has also mentioned, the alarming signs should be there. The alarming signs could be of the worsening of the blood pressure, uncontrolled blood pressure, even after giving the antihypertensives. Then there can be severe headache or visual disturbances. There can be, she throws some convulsions. There can be right upper quadrant pain, nausea, vomiting, then increased liver enzymes to more than twice normal, alanine and aspartate transaminase, increased creatinine to more than 1.1 milligram per deciliter. So these days, even proteinuria more than 2+ is labeled, but these days proteinuria and oliguria and the fetal growth restriction
not considered as features of severity. Yes, you're right.
So my initial investigations I would go for would be the complete blood count and the RFT and the LFT, and then maternal ultrasound to rule out any changes in the liver, those of hypertrophy or increased echogenicity, and then there might be some ascites to rule out any pleural effusion. Then along with also the fetal growth monitoring has to be done. First fetal scan to record the estimated fetal weight. then the placenta to show any premature aging in placenta, then the amniotic fluid, and then the uterine artery and the umbilical artery Doppler. I would be doing. And then if I think that all these findings are in range and there are no alarming signs, I can label her as mild hypertension, and I can
non-severe hypertension. We will call it as non-severe hypertension. Yes, very well discussed. Yeah, Dr. Richa. Yes. So now
outpatient management.
Yeah, very well discussed, Dr. Richa. Now we go to Dr. Deepika. So we have categorized her as non-severe hypertension. Would you start her on antihypertensives? Which antihypertensives you want to start? And what are your therapeutic goals as well?
Yeah, if her BP is above 140/90, I would like to put her on oral labetalol. I will start with 100 milligram twice a day. And obviously, it's a safe. I have to rule out whether she's asthmatic or not, any previous cardiac problems or not. Her
exactly. That is why we want to. So she is non-severe. So you have two options, or maybe I will say you have three options. So can you just talk about those three options?
Yeah, first line is labetalol. Second, we have Hypertensive. And third, but not the most popular nowadays, is M-Dopa. So labetalol is my first choice. I will try to, I will put her on labetalol 100 milligram twice a day. We can go from 200 to 1200 milligram. And it's a non-specific alpha and beta blocker. So we have to see if patient is asthmatic or not. She's had she's not in CHF, and her baseline heart, she's not bradycardic. So if on labetalol it's not controlled and second line drug is needed, then we can add nifedipine. But we have to see that in nifedipine is given, baseline heart rate should be preferably less than 100.
Correct.
Again, cardiac abnormalities problems should be ruled out.
Yes. So that is how you decide which drug. So Dr. Aarti, over to you now. Are there any guidelines which tell you about at what level you should start antihypertensives?
Good
Just
evening,
to
ma'am.
talk about the evidence, yes.
Yeah, good evening, ma'am. Actually, different guidelines talk about different range that they should start. If I talk about ACOG guidelines, according to them, they say that if the systolic blood pressure is more than 160 and diastolic blood pressure is more than 110, then you should start. Or if the BP is less systolic and diastolic, but yes,
is it, my dear? ACOG says 160, 110, that is for severe hypertension. But just to start the antihypertensives.
Ma'am, I'm coming to that.
Yeah.
If it is less, like it is between 140 to 159, and that also between 90 and 109, plus they.
You are muted. You're muted. Please unmute yourself. Dr. Aarti, please unmute yourself. Yeah.
As they say, if the BP is 140/90 and there are more readings, not single reading will not decide about antihypertensive. But if there is more than 2 reading and it is not decreasing, then we should start an antihypertensive drug, and the goal should be to maintain between 135 to 85. And if she's postpartum and she was not on any antihypertensive drug, and now the BP is more than.
Have nice guidelines which till date they say that if the blood pressure is above 150 by 100 millimeter of mercury, which is of course a confirmed hypertension, then you start the antihypertensives. But World Justice Organization says that even with 140 by 90 millimeter of mercury, you should start antihypertensives, because patient may suddenly progress to severe hypertension and she may even convulse. I'm sure many of you must have observed this, that even with 140/90 millimeter of mercury, patients may convulse. So 140 by 90 millimeter of mercury is the ideal blood pressure reading where you have to start with antihypertensives. Definitely, we have 3 options as we have talked about: tablet labetalol, tablet nifedipine retard, and tablet alpha methyl-dopa. So we have 3 options, but somebody said M-Dopa is very popular, but I'm sure we are not getting it. So M-Dopa is not available nowadays.
I said earlier it was popular.
Yes,
Yeah.
it was popular. So, Dr. Giri, once again, back to you. Why do you prefer labetalol? Why, I mean, all of us rather, why do we prefer labetalol for a non-severe hypertension as the initial drug?
Actually, labetalol, since more than a decade now, it has been proven. Its safety profile is very good. In placebo-controlled studies, also treatment by labetalol in mild to moderate gestational hypertension, it has demonstrated good efficacy without any side effects, without any increase in IUGR, without any increase in neonatal hypoglycemia. Onset of action is within 30 minutes, and in India, the practical problem is, at least in my part of the country, it's readily available, easy to use. The dose efficacy is good, safety profile is good, and you have such a wide range of dosage. You can go up to 1200 per day. Efficacy is good. Efficacy is the single most important. Rapid onset of action. There are side effects like lightheadedness, dizziness, and some patients will come and tell, I don't.
Any contraindication for this drug?
Same as Madam Chima has beautifully shown that if there is bradycardia, CCF, and asthma and diabetes mellitus, that is a contraindication which she has highlighted so beautifully. Punjab is full of our diabetics. All our Punjab, the teachers and all, they are getting pregnant at mid-30s. Most of them are diabetic because lifestyle is so bad here. So this is something which we all need to learn from today's seminar, that should we give it to the overt diabetics. She did not mention GDM. So overt diabetics, we are to try to avoid labetalol, and those with pulse rate more than less than 100.
Correct. So
then there will be a group who will not tolerate labetalol. They will come back the next day and tell you, I'm having palpitations, lightheadedness, dizziness, what have you given me? But that is a conundrum, because they will have worse than this with nocardia. Nifedipine causes more facial flushing and tachycardia. So that is a little difficult to treat group.
Perfect.
So,
very, very practically well discussed, Dr. Guinea. Only additional point here is it is available in injectable form as well.
Yes.
So your patient is on oral labetalol and you suddenly find that she's developing now uncontrolled hypertension. You have a choice to give injectable labetalol as well. This is just the theoretical aspect. I will not cover how it acts alpha receptor and beta alpha blocker and beta blocker. So over to you, Dr. Dinesh.
Yeah, good evening, ma'am.
Yeah, good evening, Dinesh. So, why not alpha dopa? Half part I have already told you, it is not available, but why not alpha dopa? Please discuss about this.
Once it was a drug of choice when we used to use alpha dopa a lot, but you know that alpha dopa is not available nowadays. And first of all, and second is that it has got a long duration of onset of action. But you have to achieve the lowering the BP. Then you have to start one day before. Then if you start today, the effect will come tomorrow, and you have to give. One has to give loading dose also to ensure that adequate control of blood pressure is there. And also in Cochrane studies, it has shown that when they compared the calcium channel blockers with beta blockers and calcium blockers with methyl dopa, the results were better with the labetalol group than with the methyl dopa group.
Correct.
So death and small progesterone age and preterm labor, these are not very much effective or not very much positive outcome was there. And above there is postpartum depression also. And also the patient who are on MAO inhibitors, you should take MAO. There is chance of reaction of MAO cheese reactions there.
Correct.
And autoimmune test also false positive there. So these are some of the problems because of which we nowadays are not using methyl dopa, and also the widely availability of the labetalol, which provide good BP control, good Bishop score, good sponsor delivery, and no postpartum depression, and good control of BP. There are some positive drugs. So we are now switch over totally to labetalol in spite of methyl dopa.
Correct. Very well discussed. So even if it is available today, it will not be a drug of choice, because basically, as you already said, it's got a very long onset of action, more than 24 hours. One day you give one TTS, even second day you don't get any effect. And when you try to increase the dosage, suddenly there is a fall in blood pressure. So that is how you have to monitor a lot. And of course, the postpartum depression, even the sedative effect of this drug. Sometimes the postural hypotension was quite significant, and it used to be it's the severe headache. we have to actually think whether it is because of the hypertension or because of the drugs. And certain side effects like thrombocytopenia, hemolysis, which is also because of hypertension. So that you have to really tally whether it is because of the disease or because of the treatment. So I think Dr. Vidya, you can take over for some questions. You can go ahead with, then I can chirp in between.
Hello.
Dr. Vidya?
Yes. So I think our panelists are very, very well read, and I think Punjab, definitely there are so much they have learned about the prediction and prevention. I just wanted to know what is in their private practice, how many preeclampsias they are managing. And one comment I want to do on antihypertensive, that all antihypertensive drugs, they cross placenta. One should remember this. And there are no randomized control trials to base any strong recommendation for use of one drug over another. Earlier, we used to have methyl dopa, and we know the whatever the side effects that as postpartum depression and the action of methyl dopa, it takes so much time to act upon. So methyl drop is dropped. In between, we were using about this nifedipine, then labetalol. But it is again the choice of the doctor as well as the compliance of the patient, both we consider. So what is any role of bed rest, salt restriction? Anybody can take this.
Hello.
Do you advise, Dr. Richa?
Yes,
you are audible, Dr. Richa. You have to rename yourself. You have to rename yourself and just tell me if any patient comes to you and her mother-in-law, every family has come in your consultation room and suddenly you detect that her blood pressure is 140/90. Whether you will advise her bed rest, salt restriction?
No, ma'am. Bed rest and salt restriction has no role in preventing the development of severe hypertension. And as far as starting on antihypertensives also is concerned, for cases with non-severe hypertension, we should better be going for twice weekly BP monitoring along with the lab investigations, and advise her always to take care of the alarming signs of severe hypertension. And we should avoid starting antihypertensives.
So in your practice, yes, Richa, in your practice, if the patient has 140/90 millimeters of mercury and you have taken detailed history, no risk factor on history
No,
also,
I will not
start antihypertensives?
No, ma'am, I will not start her on antihypertensives because
when you will start her on antihypertensives?
Ma'am, if I feel that she is having persistently raised blood pressure, or there are any alarming signs, or I am having the Doppler findings of fetal growth restriction, or I am having her altered lab parameters, only then I'll start, because lowering down the BP further will compromise the fetoplacental circulation, and it will not be beneficial to the mother. So it is the ACOG also recommends that we should not lower down the BP less than 135/85 millimeters.
I just come in here, Dr. Richa. I think we are confusing with the two different issues. When to start antihypertensives, there is a definite guideline, as well as world justices, and we do not have any second opinion. 140/90 millimeter of mercury when you have features of preeclampsia. It's not all about severe hypertension, but once you label the patient as hypertensive, we have to start antihypertensive so that she doesn't progress to very severe hypertension and preeclampsia, eclampsia. Here, the NICE guidelines say that 150/100, World Justice says 140/90. It's the only difference of opinion here. Otherwise, starting antihypertensives for a non-severe hypertension is accepted worldwide. Now, as you are talking about alarming symptoms, alarming signs, and blood pressure of 170/110, that is for a very severe hypertension, which we label it as impending eclampsia. Okay, so when you have all these features of severe hypertension, that is the time where you have to, in fact, add magnesium sulfate. for this, along with the antihypertensives. We are coming to the discussion here now. So, Dr.
this
Vidya,
patient, this patient, she was labeled as a mild hypertension, that is non-severe, and she was sent home. She was asked again to come for the follow-up after 1 week, or if she has any symptoms. And after 5 days, the patient came to your hospital with severe headache, nausea, upper abdominal pain. And on recording, the blood pressure was 170, 110 millimeters of mercury. She had the deep tendon reflexes were brisk, epigastric tenderness was there. Now, how you will manage this patient?
Ma'am, I will admit this patient immediately in HDU because she is having impending eclampsia. So she should be in a quiet room. Immediately, pulse ox will be put on, her BP, pulse rate, saturation will be monitored.
So is it a hypertensive crisis, urgency, or emergency? How you differentiate this?
Ma'am, it's an emergency because the patient is going into multi-organ involvement and she can throw fits anytime. So
yes,
hazardous or not only for her, for the fetus as well.
Yeah, so it is an emergency, so you have to control as early as possible. So usually in hypertensive emergency, there are so many end organ damages. It can happen. So what all can happen in hypertensive emergency?
So, ma'am, she's at the risk of HELLP syndrome, eclampsia. So I'll put a whiteboard. I will gather my team and I will put a whiteboard cannulas and investigations immediately for CVC.
See, there is a difference. Why whiteboard cannula?
Because if any intervention is required later on, so we have a secured IV access. So
IV for what? What IV? What you will give?
Venous access, sometimes veins collapse in such patient, they can go into shock as well.
See, don't confuse between postpartum hemorrhage and hypertensive emergency. We do secure the IV line, but we don't push on the fluids.
No, I'm not asking to push on the fluids.
Usually there is a confusion and patient is not. This shock is different. Patient might be in stroke. Okay. Patient might be in stroke or changes in the mental status. Like
secure an IV line.
Yes. I would just clarify a little why this question Dr. Vidya has asked, whether it is a hypertensive urgency or emergency. Because urgency, you may just have a very sudden severe rise in blood pressure, which is acute and not causing any end organ damage. Whereas in hypertensive emergency, you have the features of end organ damage. So all the liver enzymes, renal parameters, whatever investigation you do, you find that they are impaired, and that is how you label. So here in this case, what is to be done is this emergency that has to be controlled as soon as possible. And
so how you will control? That is a question. So
Yeah,
how you will control?
I'll send CVC, coagulogram, RFT, LFT, uric acid, put a Foley's catheter in and do urine dipstick. And along with that, I'll give her loading dose of libitalol, IV, 10 to 20 milligram within 10 minutes. And again, if her BP doesn't settle within 10 to 20 minutes, then again 20 to 80 milligram till maximum 300 milligram is reached. Simultaneously, I will give magnesium sulfate Pritchard's regime, 4 gram IV loading dose. Along, I will use 50% ampoules so that they make 1 gram, easy to make the dosage. 8 ml of those, 12 ml of saline in a 20 ml syringe to be given within 5 to 10 minutes IV. And then after that, 5 grams deep IM on both buttocks, so 14 grams loading dose. And after the mother is settled down, her BP is controlled. So then the next parameter is to watch for fetus. I'll put her on continuous CTG for the meanwhile. Give Dexa cover, 12 milligram IM stat. Previously, she was not given. And
what did you talk about magnesium sulfate in this case?
Ma'am, loading dose, ma'am, 14 milligrams. 4 grams IV and 5 grams in each buttock.
Yes, because this patient has got 170, 110, DTR brisk and epigastric tenderness. That is why prophylactic magnesium sulfate. Though we say it as prophylactic, the dosage is the same.
Yeah,
same as therapy.
High risk consent for her. We may have to deliver for the sake of the mother. So everything has to be written down and informed consent taken. Blood has to be kept in hand, and we see accordingly if patient settles within next 6 to 8 hours or not. And simultaneously her lab parameters, what the result comes.
So in this patient, you are suspecting imminent eclampsia. You must see, you have to examine everything and find out which organ damage it is predicting. You have sent the investigations already. And about the drugs, which in stepwise you are using in your protocol, first you will always use intravenous labetalol in your hospital.
Yeah.
Or
Yes,
oral nifedipine. Never use
intravenous.
nifedipine sublingually.
Yes, ma'am. Intravenous labetalol is the first choice because we have want to control her BP in a slow and controlled manner, but not to give her sudden postural hypotension as well, because it can be disastrous as well.
What happens if the blood pressure is lowered suddenly?
When blood pressure is low, because there's sudden peripheral vasodilatation can occur and there can be patient can bleed.
So we always, whenever we are talking of hypertensive disorders of pregnancy, we talk of mean arterial pressure, right?
Yeah.
So we have to aim at reduction of this mean arterial pressure by almost 15 to 25%, not more than that. Okay?
Yes.
Yes. So you have to aim at not sudden lowering of blood pressure, but a gradual one. So you all know the dosages of labetalol, nifedipine, and hydralazine, and definitely you have listened to carefully about Dr. Chima's wonderful talks. She has covered all the antihypertensives very nicely, and hydralazine, though it is not available here, but in many of the ICUs at the major cities, they are available in ICU. So actually this choice is first, if it is available, hydralazine is also a good choice for in a emergency treatment. Okay.
And we have to, if we give hydralazine, we have to preload the patient with 500 ml of precipitate.
Yes, yes. And dose titration is very important and monitoring is very important when you are giving hydralazine. Okay. So you should know what is the dosage, correct dosage of this hydralazine again. Okay. Yes. Can anybody tell about nifedipine? Anybody is using nifedipine as a first line of drug?
Yes, ma'am. I have been using nifedipine because in mild cases of mild preeclampsia 140/90, I normally give 10 milligram of nifedipine twice daily. And if there is required, then we increase the dose because it is very easier for the patient to take and widely available. And if required further on admission only, we give a labetalol.
Yes. So you are using combination. First you are giving nifedipine and then labetalol, or first labetalol and then nifedipine, or only nifedipine?
For first nifedipine, and if required, I add on labetalol.
See, labetalol and
severe hypertension.
Ah, yes.
For see, I just share my experience with all of you. Since last 30 years, I have been managing very high risk cases, and severe hypertension, capsule nifedipine. That is the drug of choice, which we have been following till now. Given a choice, because labetalol intravenously, you definitely need to monitor. Once you're well versed with the monitoring and administration, there's absolutely no problem. But if you don't have intravenous labetalol, nifedipine is a very good drug, and 10 or 20 milligram capsules, 10 milligram capsule, you can, if needed, you can give it as 2 capsules. And the onset of action is immediately within 5 to 10 minutes. The peak action is at 30 minutes and it covers almost for 6 hours. So for severe hypertension, it is definitely a good choice.
I agree with Sneha. And earlier, the capsules were punctured and they used to give sublingually, but that is very, very dangerous. And we should not give it because it suddenly lowers the blood pressure. So
we have been doing this in our PG days.
Yeah. You must have done that, but that has got a disastrous effect. So this picture you remember. So you never give sublingual. That is what we want to convey. Okay, and there are slow release preparations are also available. Okay, another newer drug is nicardipine, and she mentioned about this also. At many places it may not be available, but it is again a good drug which can be used in emergency. Okay, so another any other drugs you have used, or your ICU fellows or any physician you must have seen using, that is esmolol. This is another drug to be noted, that is esmolol. So this is again a beta blocker, and it is a very good drug available for intravenous as well as bolus as an infusion. So it is suitable in situation with increased cardiac output, heart rate, and blood pressure. So it has got a proven safety with the cases of acute MI. They use in ICU. Commonly.
Yes, only persistent fetal bradycardia, that is a disadvantage.
Side effects, yes.
Used mainly in post-op patients, atenolol and esmolol we are using in post-op patients, post-op hypertension.
Yeah, yes. Now, in this patient, when you will terminate the pregnancy? Prior to 34 weeks. So it is a severe hypertension. We say that it is 34.
Yeah, I think we go to Dr. Guinea. See, you have very well explained that you have to continue this pregnancy to till 34 weeks at least, in spite of having a very severe hypertension. You are monitoring the mother, you're doing so when we have already, I think, discussed, but if skip once again, I say that if the liver and the renal parameters and even the complete blood count, if they're impaired at any point of time, you need to monitor them very frequently, maybe every third day at least. If they are normal, maybe you can monitor every weekly, but they are impaired, then you need to monitor it every third day. If they are severely impaired, maybe every 24 hours. And now, if you feel that everything is going on well, when do you terminate this pregnancy or the expectant management, I would ask you, Dr. Guinea?
Everything is going on well, not the question which is there on the screen, right? If all is going well, there is no end organ involvement, there is no complication, we are attaining a good tight control that is below 140 and above 130, and she's 85 to 90 diastolic. Yeah. 37 weeks, 37. And the fetal Doppler is normal, and I think 37 weeks is the cutoff.
So that is what our aim is. So we want to achieve 37 weeks. But what are the findings or investigation that would warrant the termination of this expectant management as far as the maternal as well as the fetal monitoring is concerned?
Ma'am, maternal would be the same: sudden headache, elevation, fluctuation in blood pressure records, or if there is elevation above 150 and the diastolic is persistently 100 or above, headache or alteration of sensorium and right hypochondrial pain, or the platelets have started falling down, OTPT is elevated. The same things that, or there is a rise in the creatinine.
Correct.
The same things which.
Yeah, whatever the end organ damage has happened, if at all there are, either she suddenly throws a fit, maybe there is sudden abruptio placentae, she's showing all the features of HELP and acute renal failure. These are the conditions. Of course, fetal Doppler, if there is, absent or reversal of end diastolic flow. Of course, you have enough time. By then, you must have given magnesium sulfate. She's already receiving, but corticosteroids is the most important thing. So, Dr. Dinesh, what is the role of prophylactic magnesium sulfate? What we have talked about. The patient has not convulsed, but we have given her prophylactic magnesium sulfate. So what do you feel? How do you give this? What is the regimen like?
We use only a loading dose of the Pritchard regime in the common practice as a loading dose or for the prophylactic.
Which is not true, which is not correct. So whether I have said this, that whether it is a prophylactic treatment, prophylactic magnesium sulfate or therapeutic, the dosage of the complete regime has to be followed. It is the complete loading dose, that is 14 gram initially, and then every 4 hourly 5 gram deep intramuscularly for 24 hours after the last convulsion or delivery, whichever is later. That is what the message here we want to give. Whether it is prophylactic or therapeutic, the dosage and the regime has to be followed as completely. You should not give half-hearted magnesium sulfate. Okay, so that is the reason this question is here. Whether you follow juice pans or pre-charts, it has to be a complete regime for 24 hours. So you can just tell us about the practical tips here, whether you follow the juice pans regime or the pre-charts. You have said pre-charts.
Yeah, I have been following picture regime so long. And one I want to highlight here, because of the for the Western countries and Indian mothers have got less body weight and less bone mass, so we can also decrease the dose. One of the studies done at the Bakar Medical
2 grams.
College,
Yes.
Yeah, we are just decreasing the dose of, instead of giving 14, we are giving 10 gram, and we have achieved the same result. Giving the 10 gram loading dose and followed by the maintenance dose. So instead of 4 gram, there was a 2 gram IV initially, and the 4 deep IM, alternate 4 hourly.
Yes, there are few people who are following what is called it as low dose magnesium sulfate regime. That is that obstetrician is from Maharashtra only. That is called as Sardesai regime for magnesium sulfate.
And even in Karnataka, Ballari, Dr. Joshi's regime is famous. That is Jim's regime. But what I want to say is that there should be some publication, some guidelines. Suppose the patient throws recurrent convulsions, and if the patient goes in stroke or something like that, we should have some evidence to show that this is a standardized regime which we are following.
So the message from this platform is, once again, whether it is a prophylactic magnesium sulfate or therapeutic magnesium sulfate, the dosage and the schedule has to be followed as Pritchard's magnesium sulfate regime for 24 hours, because this is the most evidence-based regime. As we do not have the evidence, sufficient evidence to protect ourselves, we cannot use low dose magnesium sulfate regime. Here, once again, you have Zuspans regime, which is also well accepted and is backed up by the evidence. So here in Zuspans, what they give is they give 4 gram intravenous as loading dose slowly, as we give it for initial 4 grams, how we prepare it, that 1 ampoule has 2 ml, that is 1 gram of 50% of magnesium sulfate. So 8 ml, that is 4 ampoules as 8 ml, and you dilute it in 12 ml of distilled water or normal saline. That is total of 20 ml. You give it slowly over 5 minutes, and then hourly you maintain it as 1 gram per hour for 24 hours. That means if you have a pint of 500 ml of fluid, you add 5 gram. But because of this, I think somebody was discussing about the fluid management in preeclampsia. So you have to here actually restrict the fluids. So giving 5 gram in 500 ml of normal saline or the ringer lactate will increase the load on the heart, and she may go into failure, or her interstitial spaces will be full. So that is why nowadays you have the concentrated solution of magnesium sulfate, that is in 100 ml. That is also a good choice. But from this platform, we want to give a message that this standard Pritchard's magnesium sulfate regime is only accepted, and Zuspans regime in standard form can be given.
And then we have to monitor for respiratory rate during output.
Yes. And so dip tendon reflexes, respiratory rate, and urine output. Suppose they are any of these are adverse, then what will you do?
Then stop the magnesium sulfate, and then if the respiratory is too much depressed or reflexes are too much depressed,
stop completely or withheld only that particular dose of magnesium sulfate.
Yeah, withheld for the meanwhile. We have the normal level is 4 to 8 milliequivalents. So we have to see what is the level and how sick the patient has been after magnesium. If the condition reverses, then we can again try with the lower dose. But if it doesn't go well, then we have to get 10% of 10 ml of calcium gluconate as an antidote.
Yes. Any comment, Dr. Vidya?
I'd like to add one thing, if you permit.
Yes.
A PGT, Saint 140 and she was put on sulfate. And
how much was the blood pressure?
140 by 90.
140 90.
Yeah.
Why do you start magnesium sulfate?
Because of the she was features of convulsion. And
Okay.
what happened that she, after giving magnesium sulfate 2-3 doses, she had a choking sensation. She was unable to take intake for oral fluid, anything.
Yes.
So that was one of that also how.
But Dr. Dinesh, what it is recommended is that meanwhile, in between the two doses, you have to monitor the respiratory rate, tendon reflexes, and urine output. In fact, deep tendon reflex is the earliest to go. So if you are monitoring it properly, if you are examining the patient, you will find that the reflexes are absent. Then you will not give the repeat dose. So why she should have toxicity? Basically.
She had, I think, what, laryngeal edema or what problem she had?
No, she was unable to take any fluid, and she gasped and she had aspiration only. And she later on she succumbed because of this.
Pulmonary edema.
Pulmonary edema or maybe aspiration, because when the patient throws a convulsion, we put her on the rail cot and make her to lie on the one side. Isn't it? Tongue bite is common, aspiration is common. So those things are very, very common. So we have to take precautions when we are managing these eclampsia patients. Right?
So not to get confused and distracted by these features, because if you are giving magnesium sulfate, you have definite parameters to be monitored. And if the parameters are well, you can definitely give the next dose. If there is any impairment in any one of these parameters, you have every right to stop or withhold that particular dose of magnesium sulfate. And by the time when the next dose comes, meanwhile, you are monitoring all these parameters once again. If you have the reflexes which is present, the urine output is good, the respiratory rate is good, then you can definitely complete your dosage of magnesium sulfate regime. But anytime you find that there are features of toxicity, you will have to withhold of course, earliest you have to withhold. You don't wait for the toxicity. And yes, of course, smaller places do not have facilities for monitoring the magnesium levels. So I think we do not talk about the theoretical aspect of it. I'm sure there are many senior gynecologists and obstetricians here who have been using magnesium sulfate for long, including me. I'm using since last 30 years in my practice, and maybe 3 years earlier during our residency, but we have not observed a single case of magnesium sulfate toxicity. So I think that simple is that the monitoring is very, very carefully, it is to be done carefully. So you can take up, Dr. Vidya.
Suppose this patient has got features of severe preeclampsia less than 34 weeks. So usually we always advise, if the patient comes to you less than 26 weeks, you have to stabilize the patient and terminate the pregnancy. The problem is between 26 to 34 weeks. So we do give expectant management. I want comments from all the panelists. If the patient comes to you at 32 weeks as our patient, so how long you will continue the expectant management, and what monitoring you will do, and what are the fetal and maternal indication? Maternal indication definitely we discussed, but what about the fetal indication for termination of the pregnancy?
Ma'am, if we have given magnesium sulfate to the mother, and if she doesn't stabilize within next 6 to 8 hours, then definitely we have to deliver. Keeping them.
Yes, so we were talking about the neonatal outcome, no? So we are worried about that. We have given the steroids. So
preeclampsia continuous CTG will monitor. If her after resuscitation, even then the CTG pattern is pathological or non-reassuring, then we may have to do her vaginal examination and do Bishop scoring, whether it's favorable or not.
Yes.
So accordingly, if the baby is too sick, then we have to be emergent cesarean. But
so it all depends on your Dopplers, about the biophysical profile, all those things for the neonatal outcome. We are giving her steroids, but we have to see the maternal compromise as well as the fetal compromise, both. So we have to monitor both. And it is very sometimes a difficult decision for the termination of the pregnancy. So whether you will, suppose you have given the steroid, patient has continued very well, she is responding to you and she is monitored well in the hospital. So whether you will give repeat steroids, and if this patient starts any bleeding or any abdominal discomfort, what do you suspect?
Ma'am, in the first answer, we can give repeat steroids if more than 7 days have passed from the previous. But we have to counsel because she is less than 34 weeks, yes, we can give for the safety of the baby. And if the patient has abdominal pain or spotting, so I will first think of abruption.
So what we say is, in severe hypertension at 34 weeks, we terminate the pregnancy.
Yeah, for the sake of the mother is always a priority. If patient is having bleeding and tense abdomen, I'll put her on continuous CTG, and we see for the increased tone in between the contractions. Obviously, fetal heart will also dip if she's having abruption. Do a secure and IV access. Send her, see her in latest investigations. Go for blood. Blood should be gotten cross-matched, and do a gentle PV examination to see her bishop scoring whether she's progressing having vaginal delivery, because many of these patients, they go into labor spontaneously.
So abruption is always a common complication with preeclampsia, right? So any patient has got abdominal discomfort or localized tenderness or any spotting, we immediately suspect accident. So abruptio is a common complication, and you have to always keep in mind that it is a disastrous, and so many complications occur once patient develops this abruption. So how you will act? We will not go for Bishop score and all. Now, once abruptio occurs, immediately we think of cesarean section. We are not going to induce because we have to save
not induction, but if she may have already be 5 or 6 centimeters, because these patients sometimes they silently dilate. So I can do for trial of delivery, taking not that much of time in OD, keeping anesthetist and pediatrician there only. But if the fetal heart is not that bad and delivery is not that far, but I won't induce.
The fetal heart is good. She is 34 weeks. She is having abruptio. So
yeah,
what?
Then, obviously, then cesarean.
Cesarean section, obviously, no. So
suppose if the fetal heart is good and you have abruptio, and you try and wait for the delivery, and suddenly the complete placenta separates in next 5-10 minutes and the baby goes, then how will you explain? So
I had one referred.
We have many cases.
Many cases
but then evidence doesn't support this, so we have to, and medical legal again. So once in a while in medical college, all of us have done this. Yet it may be 6 to 8 centimeters. She will deliver fast, and that's all. But the things don't work that way every time. So in a medical legal way, also you have to think. And of course, when you have a live fetus, why do you want to risk the life of?
I'll call the anesthetist, but we are working in peripheries in private practice, so we don't have 24-hour anesthetist. So the time the anesthetist will take to come. So I had one patient. She had come with a BP of 220 by 110. She was having abruption. I did pervaginal. She was 2 centimeters. She was second gravida, and within 20 minutes she had full effacement and she delivered spontaneous vaginal delivery. So I had no time to call
So that is an exceptional incidence, you can say. But here our patient is only 2 centimeter diameter, and she has dilatation only 2 centimeter, and the fetal heart is 110, 120. So you have no choice but to go for cesarean section. So what questions you want to ask, Madam Vidya Thobi?
Yeah. What we know that there is an abruption. What investigations you will do?
CBC, PT, PTI.
Yeah, USG shows a live fetus, retroplacental.
Dr. Aarti, you can take up this. You can take this discussion ahead.
Yeah. This. Dr. Aarti, long time I have not heard you.
Actually, all were busy with Deepika.
Whatever it may be, this patient has landed with you. So now you tell me that correlation profile is done and the platelet is 50,000. Now you see you have to talk with anesthetist also. So bleeding time 5, clotting time 8, fibrinogen 150. So FDP is present. How you will proceed?
Because the platelet count is very low. It's an abruptio. GA will be the preferable
So what are the problems with the GA?
Ma'am, during intubation, one thing is that intubation can always, like whenever we are giving, doing intubation, there is a hypertensive response to intubation. And that causes more hypertension.
Yeah, difficult. Intubation might be difficult. Yes.
Yeah. Other thing is, ma'am, there is lack of analgesic component in GA that will release more catecholamines. And as a result, it can raise the intracranial hypertension. The third thing is, like for such patient, like she was giving magnesium sulfate also. So this magnesium sulfate that sometimes prolongs the effect of these muscle relaxing agents. So neuromuscular monitoring is also advisable. And post-op also, we need to keep them on ventilator for a little while to avoid any residual post-op chlorization when magnesium sulfate is being given. And this platelet count is so less, nobody will go for a regional anesthesia at this time with 50,000. And fibrinogen, if we see, it is 150. So I would like to have in my hand FFP also at that time, and taking care that I don't overload the patient, that fluid overload should not be there. Taking care the various lines the anesthetic can put, like arterial line, central line, so that we can monitor the fluid intake and output in a better way. That should always be there. And this should all go on simultaneously with the preparation of the earliest delivery of the baby. Because now the baby life and the mother equally, they are on stake when there is abruptio, and the baby may be compromised and we may get a dead baby at the end if we are prolonging it too much.
Ma'am, one point that magnesium sulfate also relaxes the uterus.
Yes, it relaxes.
Yeah, that is also there. Yeah,
it does
oxytocin
relax.
is the drug of choice for preventing the blood loss in such cases, rather than the other drugs. We all know we can't give.
Yes, so the choice of anesthesia is always epidural. If epidural is not available, then we can give in selected cases spinal, no doubt. But then the contraindication is again a platelet count and DIC. Can anybody tell about the DIC? Many times we see this patient go in DIC. And what is DIC score? Is it helpful, this DIC score? So this DIC score is very helpful. It takes into account about the platelet count, more than 1 lakh, 0, 50 to 1 lakh, that is 1, and less than 50,000, 2. And elevated fibrin markers like FDP and D dimers, if there is no increase, 0, moderate increase, 2, and strong increase, 3. PT, if it is less than 3, 0, 3 to 6 seconds, 1, and 6 seconds, 2. And fibrinogen levels more than 100, that is 0, less than 100, 1. So these parameters are taken into account, and then we formulate the DIC score. So in these patients, we have to find out that you have to add these scores, and if the score is more than 5, there is a over DIC. If it is less than 5, non-over DIC, so we have to repeat test again. So after 1 or 2 days. And if it is over DIC, you have to repeat the test after 6 to 12 hours. So you can score the daily. So you have to, whenever this DIC score, when there is over DIC, what you have to do is we have to make available of the various blood and blood components. Always senior obstetrician, senior anesthetist, and it is a multidisciplinary approach when the patient goes in DIC. So always we talk of this abruptio is very dangerous to manage than the placenta previa, right? So availability of these blood components and various products must be available, and maybe you have to manage such patient in tertiary care center Okay, so you must have seen these patients very often going in for DIC. So monitoring is very, very important. In this patient, what was done was fetal heart was confirmed, emergency section was done. Then what happened is patient had some convulsions. So MRI was done. So there was bilateral parieto-occipital lobe, subcortical, there was edema, low density areas of white matter over the posterior lobe. So the diagnosis of PRESS was done. So can anybody comment on this PRESS? Any cases you have seen in your practice or you have heard about this PRESS?
No,
Yes, ma'am, I have seen a few cases, 3-4 cases I have seen in the my 16 years of career. And it is the best thing is it is reversible.
Yes.
So
That
the
is very
naming
important.
itself is showing that posterior reversible encephalopathy syndrome. So if I take up the questions like that, if we see that a high level of suspicion is very important.
Very important.
Yeah, we should be always alert that maybe either she will come referred that a visual loss may be there. What happens in posterior reversible this encephalopathy syndrome is that it is basically a clinico neuroradiological syndrome.
Yes.
So there are clinical findings, there are neurological findings, there are radiological findings. So clinically, it is like there may be headache, seizure, altered mental status, then visual loss, and usually associated with preeclampsia and eclampsia. And radiologically, as you have shown the pictures, there is generally vasogenic edema, which is seen in the parietal and posterior occipital lobes. So when we have a high level of suspicion that this case was of preeclampsia or eclampsia, she should be immediately admitted in HDU or ICU, should be stabilized. The whole set of investigation already we have discussed, they should be sent, and immediate decision should be made that what should be done to deliver the patient. Whether you do pervaginum examination, whether you take the decision for cesarean section, that is according to the condition of the patient, because it is reversible only when the action is taken at a proper time, so that we can prevent the long-term sequelae of this PRESS syndrome. And specific measures like for anesthetist, if it is written like that, then the same goes for that only, that before we have discussed. That
Yes.
if patient is conscious, but there is blindness only, but the patient is conscious, then definitely we should go for regional anesthesia. But if the patient is unconscious, repeated seizures are there, then definitely we should go for GA. So it is accordingly how the patient is presenting, and that is how the anesthetist will follow. And
so in a nutshell, this PRESS should be recognized very, very promptly. And it is, as you told, it is reversible. And if you delay the treatment, definitely some damage is going to happen. So you have to recognize, as it is a neuroradiological diagnosis, we have to, in certain patients, definitely, if not every patient, but certain patient, when you recognize, you have to definitely do MRI and find out if there is any PRESS. Okay, so we have to reduce the edema. So we have to give some mannitol and other drugs, and you have to control her blood pressure. And if she throws repeatedly convulsions, sometimes these patients have some focus and they go for epilepsy also. So you have to give anti-epileptic. So newer drugs have come up like levetiracetam. They give nowadays for eclampsia also, they give levetiracetam very, very frequently. And the immediate delivery, as she was talking about the immediate delivery and other, even if the patient is on immunosuppressions, we have to discontinue this.
I think we will take up 1 or 2 questions what is mentioned in the chat box, and we will conclude.
Conclude. And
Yeah.
only
So
thing
you
is,
have already come to
postpartum. No, Dr. Chima was talking about the postpartum management, which is very, very important.
Yes.
48 hours monitoring is required in whenever the patient is delivered, even though severe hypertension. You have to taper the antihypertensive. If the patient is on antihypertensive, don't stop them immediately. So you have to taper them, and you have to sometimes continue some of the antihypertensives.
Up to 6 weeks, maybe.
Maybe.
And, yes, that then we label it as postpartum justosis or postpartum hypertension. But then it may continue as chronic hypertension. So after 6 weeks, we label it as chronic hypertension. But even the pure preeclampsia or hypertensive disorders of pregnancy, the hypertension can continue up to 6 weeks of postpartum or post-delivery. And that is why we were talking about the delivery of the products of conception, the baby and placenta, doesn't relieve the patient of the symptoms and signs of preeclampsia. So with this, we just come to an end of this panel discussion. And there are 1 or 2 questions here in the, somebody has asked whether 14 weeks pregnancy, 220 by 110 blood pressure, the patient has all the symptoms and signs of, the alarming symptoms and signs. Naturally, there's no question in modern, whether it's a modern obstetrics or even the age-old obstetrics, maternal life has the first priority. Then only we go ahead and think about the fetus. 14 weeks, we have just mentioned, in fact, we have given a table saying that if there is a severe hypertension before 26 weeks of pregnancy, then we have only choice to stabilize the mother and terminate the pregnancy. So early onset severe hypertension, the management is purely in the maternal.
And one more thing is, in such patient, you have to rule out some thrombophilias. Some thrombophilia are very common in suppose the patient develops.
If we open that topic, the discussions will go a long way.
Yeah. But you have to rule out. You have to rule out.
You have to think that it is not basically the hypertensive disorders of pregnancy. The hypertension which we are defining, the hypertension which is diagnosed for the first time after 20 weeks of pregnancy is HDP justosis. And if it is occurring before 20 weeks of pregnancy, then that is not HDP, and here you have to investigate for what is the origin or etiology of this hypertension. So that is one. And I think if there are a few more questions, you can also see. But yes, somebody
only one question.
Yeah, somebody has made a comment here that if there is abruptio placentae and if the cervix is good, favorable, you can wait. But here, what case we are quoting here, she has dilatation of only 2 centimeters. The fetal heart is going down very seriously. We have to take this issue and we have to go for emergency cesarean section. Of course, we have to manage the coagulopathy simultaneously. So this is a crisis, friends. So crisis is an integral part of the human life, and those who timely and appropriately counteract it, they will survive and succeed. That is what Gita says, not us. So prediction, prevention, and preparedness, what we have been stressing right from the beginning of this pregnancy, beginning of this program, that we have to predict, right? Even not in the beginning of pregnancy, but even pre-conception, you have to see whether this patient has got some pre-existing or comorbidity, and that is how you have to triage these women, whether she is high risk for development of preeclampsia. And then, of course, if yes, then we have to start her on low-dose aspirin and high-dose calcium and vitamin D. As we have already discussed, there is no role for strict bed rest and dietary salt intake restriction. In fact, it will worsen the situation. We may land up into thromboembolic complications. And of course, antihypertensives, the consensus is that we have to start antihypertensives once you confirm or diagnose the woman having hypertension, and that is more than 140/90. Once she has very severe hypertension with alarming symptoms and signs, that is a time to start magnesium sulfate, which is same as the therapeutic magnesium sulfate, what we have been giving for eclampsia. Of course, all this anesthesia and neonatal outcome that we have already discussed, and we have to remember that not to forget, as Dr. Vidya has already said, not to forget the postpartum management of gestosis. We have to take her through this postpartum period very smoothly, prepare her for uneventful puerperium, and then, of course, see to it that she doesn't develop chronic hypertension in future as well. So with this, I thank my dear friend, Dr. Vidya Thobi, for being a wonderful moderator. And I thank all the panelists for being so proactive and having very good inputs, especially Dr. Gini Gupta and all of you. Wonderful inputs from all of you. Thank you so much once again. And I take this opportunity to humbly seek your blessings and best wishes for my candidature as Vice President Foxy from West Zone. Here you have two posts. I request one of your most precious vote for me. The elections are online. You don't have to exert anything from your side. It's just on the tip of your finger. You will receive your personalized link on your mobile, and you have to just vote for me as Vice President Foxy from West Zone. 1st to 10th August is the crucial period. Thank you so much.
Thank you, Dr. Sneha. That was a wonderful webinar, and you always speak so excellently. So I request Team Punjab, and thank you, Team Punjab also, and Dr. Kavita especially. I would like to again come to Punjab once to meet you all personally. Do come to Karnataka as well. As a Kasoga president, I am hosting one conference in 1, 2, 3 at my place. Please do come to my place and visit Karnataka. I expect all Punjab to vote, especially for Sneha. She is my dear friend, and she is so true academician. She has done wonderful work as a breast committee chair. Now she is AMOG's medical disorder committee chair, and she is doing wonderful work. She is an apt person for vice president, as a vice president. So please vote. Whole Punjab should vote for Sneha Bhuyar. There are 2 votes, as she has already told. So 1 vote for Sneha Bhuyar always. Thank you very much again. Thank you.
Thank you so much. Thank you, all of you.
Sure, ma'am.
Thank you.
All Punjab will be voting for you. We assure you our support and
yeah.
And Kavita, I heard that she is also contesting for ICOG Governing Council.
I was coming.
So I am also contesting. So whole Karnataka will definitely be voting for Kavita as well. And from Punjab, I don't know how many Governing Council members are standing, and for that also we will support. Thank you very much.
Thank you so much, ma'am, for joining today's webinar.
I wish all the very best to both of you. I have just finished my tenure as Governing Council member ICOG, and as I'm going ahead, I wish both of you all the very best for your upcoming election as GCM.
Thank you. And the panelists were wonderful, I must say. Yeah. Only few are
Dr.
leaving
Dinesh,
there, but yeah.
Dr. Aarti, Dr. Dipti, Dr. Gini, and I think
Dinesh, Dr. Richa.
Dr. Richa, yes.
Dr. Richa.
So wonderful. Dinesh, it's always a pleasure meeting you. And
he discussed his personal private cases also. That those were wonderful cases.
Thank you so much.
Thank you, ma'am. Thank you so much. And thank you to Shield Sahita Priya. She has been very patiently doing our work.
Yeah, Shield always helps us. So thank you.
Sahita Priya is excellent as far as work is concerned, and very silently she does it. You know, she excellently she does it, manages the whole show. And special thanks to you, Dr. Prachi, as well as Sahita Priya and entire Shield team. Thank you so much.
Thank you, ma'am.
Thank you, all of you. Looking forward for your support. So
Thank
1st
you,
to 10th August, Dr. Dinesh, please take care of me.
Sure. Yeah, all with you.
Thank you.